Good morning, members, and welcome to this morning's meeting of the Health Scrutiny Committee for Lincolnshire. Can we please start with agenda item 1, which is election of chairman? Can I ask for nominations for the chairman position, please? Do we have any nominations? Councillor Wharton?
I'd like to nominate Councillor Carl Macy for the position of chairman, please.
Do we have a seconder for that, please? Councillor Allen. Are there any further nominations? Okay, so it's proposed and seconded that Councillor Carl Macy becomes chairman of the Health Scrutiny Committee for Lincolnshire for 2022-23. Can we have a show of hands for those in favour, please? Thank you. There's anyone against? Any abstentions? That's carried then. Thank you very much. If you'd like to come and take the chair.
Okay, well, thank you very much for my nomination and election as chairman. I look forward to another year of chairing the committee, and thank you all for your support. I'd now like to start with the introductions. Before continuing, I'd like to welcome everyone who is present in the chamber and also those who are listening online. I would also add that for those of us in the council chamber, there is no fire drill planned this morning. In the event of the fire alarm sounding, we need to leave the council chamber through the rear doors, through reception, and assemble in the car park at the front of the building and await further instructions. I would also like to ask for all mobile phones to be switched off or placed on silent, please. I'd now like to move to agenda item 2, election of vice chairman. I would like to nominate Councillor Linda Wotton for the vice chairman. She's been an excellent support over the last 12 months, and it would be good for her to continue on. Do I have a seconder to my proposal? Thank you, Councillor Smith. Any other nominations? In which case, all those in favour, please show. Thank you. That's supported. Linda, would you like to move up? Thank you. Okay, in which case we'll move on to agenda item 3, apologies for absence and replacement members. Trina.
Thank you, Chairman. We've received apologies from Councillor Thompson, Councillor Lucille Higgs, Mark Whittington, but we have a replacement member for Councillor Mark Whittington today, Councillor Kathy Rice-Oxley. She's attending on his behalf today. And we've also had apologies from Councillor Sue Woolley, Executive Councillor, NHS Liaison, Community Engagement, Registration and Coroners. Thank you, Chairman.
Thank you, and welcome to Councillor Rice-Oxley. Welcome to the committee. We'll now move on to agenda item 4, declarations of members' interest. Do members have any interest to declare at this point? No? Should any arise throughout the meeting, then just please make me aware. We'll now move on to agenda item 5, the minutes from the 18th of May. This is to confirm the minutes that are found on pages 5 to 12 of the agenda pack, and as the committee have had the opportunity to read these in advance of the meeting, I plan on taking these on block. Is there a proposer for these, please? Councillor Linda Wotton. Seconded, please. Thank you, Councillor White. All those in favour, please show. Okay, those against? And abstentions. Thank you, they're noted. They're carried, thank you. In which case, we'll now move on to agenda item 6, the chairman's announcements. My announcements have been circulated with the agenda on page 13, and my supplementary announcements were emailed on the 14th of June. Are there any questions on these, please? Councillor Smith.
Chairman, if you'll permit me, my laptop's having issues, so if you'll permit me to wait while it fires up, which is momentarily because it's just decided to work, and I will then ask my question.
Joys of modern technology, Councillor Smith.
Yes, tell me about it, Chairman. My agenda pack wouldn't open, so I thought I'd restart it and it'd move quicker, but it's deciding to take its time. I'm nearly there. I've got them, thank you. Thank you, Chairman. Apologies for that delay. I am very nearly there. It's just deciding to process my Word document. Thank you, Chairman. It's quite clear to me the issue around waiting lists. Sorry, is that the right thing, or have I got? Oh, I've done the wrong thing. I do apologise, Chairman. That's the wrong date. Bear with me. That's apologies, Chairman. Chairman, would it be possible for our NHS colleagues to share the training and qualification that staff for the new posts in terms of the mental health have undertaken in respect to the new positions that you allude to in your supplementary announcements at point 4, whilst additional access to mental health at what is for many the first point of contact across our county's GPs is of course always welcome. As you'll know, I have previously expressed concerns of how mental health is trained, etc. So if our NHS colleagues are willing to share that information, I'd be most grateful and most interested to read about that. Thank you, Chairman.
Thank you, Councillor Smith. I'm sure we can pick that up outside of the meeting and come back to you and other members of the committee. Do I have any other questions? No? Yeah, Councillor Cleaver.
Could I just ask for clarification? Where it says in your number 4, the specialist mental support for GP surgeries, 2 mental health practitioners for every group of GP practices in a local area. Does group of GP practices in a local area mean a care network, primary care network? Or is not the same as a primary care network?
Simon?
Sorry.
I think that is the understanding, but that is something we need to confirm also. This was announced last week, but we do need to confirm that. Thank you.
And our NHS colleagues have just nodded along, so I think it is the case. So, thank you. Okay, Councillor Harrison.
Thank you, Chairman. In addition to the previous comments about this issue, I do wonder how on earth they're going to find suitably qualified people, because the LPFT is very, very short of numbers of trained people. So, is it just a wish?
I think it's a worthy question we can ask. We've got a recruitment and retention item, I think, next month anyway, so we'll build that into that and try and find out, because, yes, I'd agree with you. I think it may be a struggle, but hopefully not. Any further questions? No? In which case, I just wanted to say a huge thank you to Dr. Brian Wookey. He's been a member of this committee now for many years, and even before my time was a member, and he's been a very good addition. Every time he's spoken, he is always a font of knowledge, and I think it's been very appreciated. So I wanted to wish you all the very best for whatever you do moving forwards, and you'll sorely be missed.
Thank you very much, Chairman, for those remarks, which I'm not sure they're all warranted, but anyway, they're very much appreciated. I've been a member, or not a member, an attender for, actually, I thought it was about 5 years, but it's actually about 7. And so I hope there's been a contribution, and most, I hope, of it has been through our work within Health Watch and now HW Links. And so I will do my best to break in gently my successor when they're appointed. So thank you very much.
Thank you, Dr. Wookie. In which case, I would like to have a proposer that we note the announcements, please. We've got a proposer, Councillor Smith, and a seconder, please, Councillor Cleaver. All those in favour, please show. Thank you. That was unanimous. Thank you. Okay, in which case, before we move on to agenda item 7, I just would like to ask that you keep your questions and contributions succinct and concise, and ideally no more than 2 questions per person per item. I would also like to stress the importance of treating all our contributors today with respect and to bear in mind our role as constructive scrutineers. I'll now move into agenda item 7 for NHS services in Lincolnshire. This item was circulated as part of the agenda pack from pages 15 to 328, and I draw your attention to the resolution from yesterday's extraordinary meeting of the South Kesteven District Council on Grantham A&E. Our presenters from Lincolnshire Clinical Commissioning Group today are Pete Burnett, Systems Strategy and Planning Director, and Tom Diamond, Associate Director of Strategy. And I'll hand over to you just to go through the presentation, please, and we'll ask the questions at the end. Thank you.
Thank you, Chair, and thank you, councillors, for inviting us here today to the committee. We appreciate the role of the Health Scrutiny Committee in this work, and we certainly welcome your feedback and on this matter, and continue to work with you as we take this as we move forward with these proposals. So the paper in front of you today is following the decision on the CCG board at the end of May to confirm the agreement to the proposals to make Grantham A&E into an urgent treatment centre, to centralise orthopaedic non-elective surgery on the Grantham Hospital site, to centralise stroke services on Lincoln County site, and also to arrange the acute medicine beds at Grantham Hospital into acute community medicine beds at Grantham Hospital in a kind of combined service model. I think the last time we came to you was during the consultation process. So I know we attended 3 times during that. 2 of them were a deep dive into each of the proposals during that time. And I've not actually spoke to you on this work since. So I aim just to go through the kind of work that took place partly during the consultation, and then subsequently after that to allow the CCG board to arrive at a decision where they could approve the proposals that were put forward to the board on that day. So the consultation process, as you know, ran from 29th of September all the way through to the 23rd of December in 2021. It's an extensive process that we engaged the Consultation Institute, which is a not-for-profit organisation that advises bodies that are consulting with the public on best practice kind of guidance around a whole approach from pre-consultation all the way through to making a formal decision. And we worked with them with their assurance. We signed up for their full package of assurance to work through all the kind of proposals we need to work on, and receive best practice in terms of based on their kind of criteria in terms of consultation we ran. So we ran that consultation. Following the consultation, we received just over 3,000 questionnaires. During the consultation, we had 11 face-to-face events and 6 online events to gauge the public, to real kind of public discussion around the proposal we were putting forward to them, as well as a whole range of other kind of events and and ways to publicise the kind of consultation proposals we were making. That feedback was collated by an independent organisation called ORS, who then went through all the feedback that we received, the questionnaire responses, the written submissions, because we had 14 kind of in-depth conversations. We had targeted resident survey, telephone conversations. We also had feedback from 18 organisations, as I say, who gave us written submissions, and they went through all of that and determined kind of what the support was based on the questionnaires, the resident surveys and NHS staff for the proposals, and also then pulled out all the salient points, both for, against, or what that would need to be considered as the proposals were put towards the CCG board, and then, if agreed to, implemented in that sense. So what we can say is from the consultation questionnaires and the evidence in the report provided via them, that actually both the case for change and then support for, there was more than 50% or more support for all of the proposals and the case for change. And that includes, if you break that down, that includes NHS staff groups, it includes the public on their own, and also includes the targeted resident surveys, which, to be fair, more representative of the kind of general public view in terms of statistically representative in that sense. So all proposals had 50% or more support as we went through, but we're always clear that that is helpful to know, but it isn't a vote. And we said this during the consultation. The aim is, as well as presenting what we felt was that the proposals was the best clinical model, we wanted to ensure that actually alternative options were could be captured. Wanted to make sure that identify risks that we hadn't picked up were notified, and any kind of area that we hadn't considered needed to be reviewed. So once we had the consultation feedback in, we broke down actually the feedback into those who support, those that propose a new model, those who were against, and risks and concerns. And that was broken down, that every single one of them was captured and therefore broken into and then themed around either outcomes, workforce, sustainability, travel and transport. And then we then went through a process of reviewing all those kind of questions and comments with the clinical and operational teams involved in that service area, looking at kind of what that meant, looking at the clinical evidence, that national best practice clinical evidence, as well as our own protocols in terms of, okay, how would that impact on the proposals as we move forward? And so, for example, the Grantham, although there were people who opposed the Grantham UTC change. What they didn't want was the old A&E. They wanted a full Type 1 A&E, which exists at Lincoln County. And actually, therefore, we had quite an in-depth study. Okay, what does that take to do? What would you need to do that? And all that is captured in the appendices in the decision-making business case. There's around about 25 documents that capture all that feedback. That went through a robust process then of collating it, compiling that information to inform the decision-making business case. It then went through a clinical review, went through an operational clinical review of the local service, but then we took it through a two-step process. So the first step was having the clinical director of the NHS of Lincolnshire, along with colleagues from within the CCG, both clinical, nursing, therapeutic kind of professions, to review all the information and all the response to the information given to the public, to thoroughly consider, okay, does the proposal still stack up clinically? Is the response sufficient? Have they gone through it correctly? Actually, do they support the responses given? And we had 3 meetings, quite considerable clinical meetings, led by clinicians that went through all those kind of that work. And unanimously, that the first meeting through the clinical directorate agreed with the proposals. There's quite a lot of discussion on the stroke proposal and what we've learned from the kind of the temporary change that's been in place during COVID, but all got unanimously supported through that process, and the proposed model of care was supported. That then moved into the CCG Quality Patient Experience Committee, where another thorough review took place with the CCG clinicians and the secondary care doctor on the board. Again, reviewing them and the EIAs and QIAs that were kind of presented alongside that. That was supported again, and that's what went into the support of the decision-making business case, as well as the other considerations around the kind of the 5 national tests and our local kind of criteria for assessing each of the proposals. That went to the board. And the CCG board, because of the process we've gone through in terms of coming up with the kind of 4 service models, there's been extensive clinical engagement. So both prior to the consultation in terms of developing the case at that stage, both through workshops within Lincolnshire, but then also the proposals are then scrutinised by the East Midlands Clinical Senate, that The ones that went to the public were fully supported by them. They went through NHS England's regional and national clinical teams as well, fully supported, and it come back through this process at the back end of the consultation. So the CCG board it were informed by all the clinicians involved in the review, and the advice received by them, both regionally and nationally, and national best practice, that this would the change would improve clinical outcomes, provide better quality, quicker care, and allow the patients to return to their previous lives sooner if these proposals were put forward. And that's the decision the CCG board made. So they took the decision, unanimously agreed to the proposals in their board meeting in May, and that's what's come through. That's what we're discussing today. The next steps this is a key next step, because obviously the committee plays a key part in both the consultation and the review of the decision, and then it'll be moving into the implementation stage, and then we look forward to working with you during that implementation stage as we go forward.
Okay, thank you for that. Thank you. Do we have any questions, please? Councillor Ray Wotton.
Thank you very much, Steve. Mr. Chairman, obviously, as a campaigner for Grantham Hospital, I have an opposing view to what the presentation has just given us, because back in 16th of August 2016, Grantham had an A&E, not a full-blown A&E, but an A&E, and therefore it was closed overnight and given a out-of-hours doctor's surgery, which is the word I'm not just trying to get my head around. Yes, UTC, yes, yeah, overnight. And many people, in fact, even in their own figures, they say that 700 people per year will have to travel to Lincoln who cannot be seen at a UTC in Grantham, because basically a UTC is a glorified doctor's surgery. Now, there was a proposal some time ago whereby the UTC was going to be called a UTC Plus, which would have perhaps been better, but that just disappeared. So really we are saying that lives will be lost by patients having to travel to Lincoln. Now, I'm going to go on a bit about my own circumstances. I'm back today after suffering a stroke, and my doctor sent me to A&E in Lincoln as an emergency. And when I got to A&E, I had to sit there for 13 hours before I was admitted to a stroke unit, which I think is outrageous, really. The staff on the stroke unit really gave me some excellent care, and I really thank them for that. But I don't think that I should have had to travel all that way and just sit there for a whole day, really, without any treatment. So we've had rallies in Grantham, we've had petitions down to Downing Street, and I believe that our voice has not been listened to, really. Even in their own figures, over 50% of people from Grantham wanted to keep an A&E. Not a full-blown A&E, but an A&E. I believe that we should be, as a committee, be referring this decision to the Secretary of State to look at. Thank you, Chairman.
Thank you, Councillor Wotton. Councillor Linda Wotton.
Thank you, Chairman. As always, my dear husband's captured a question that I was going to ask, but going through the paperwork, you've given us lots and lots of information. You really did listen to the fact that you needed to consult, whereas in the past, perhaps you haven't consulted quite as much. There's so much information here. I've got a couple of questions. In the paperwork, you say you're working with LCC on transport plans. Could you share this thinking with this committee, please? Also, I think it's a case of that you're going to do what you want to do. You're going to change Grantham into a UTC. We didn't put the sign up. It's always said Grantham A&E. Perhaps it's only a level 3, which you say is equivalent to a UTC. I don't doubt your words, but I do think that we used to do a lot more than what is there and available at the moment. I think it has been taken away by the back door, to be quite honest. But could you tell me, sorry, lost my page. It was on page 121. Have you identified a service provider for the UTC that you plan for us? Because before we had, I think it was Community Health Service, and they were very successful and the public did like them. But as Councillor Raywatton's already pointed out, it's a great service if you can't get an appointment with your GP, and there's a lot of that problem at the moment. Also, you pointed out that this wonderful word, nomenclature, is needed to communicate to the public exactly what the UTC is going to do. And I think you certainly do need to do that. As a campaigner, I am disappointed, but this is the result that I did expect. I do believe we have been listened to, but we've not been heard. And as I said yesterday at the district meeting, the battle is done. The people of Grantham are disappointed. They don't want to lose their A&A status, even if it is a UTC. And the people of Boston are disappointed because stroke services went over to Boston, and now that's going to be centralised in Lincoln. Thank you, Chairman.
Thank you, Councillor Wotton. We've got Councillor Allen next, please.
Thank you, Chairman. I'm very sympathetic to the comments that have been made by the representatives from South Kesteven and Grantham in particular about the decision and where that leads. I've got a more general comment. And whilst the report does suggest that some services will be moving elsewhere to Lincoln, it does seem to me that in lots and lots of these consultations that we get, it's really a consequence of wishes on behalf of the Trust to consolidate services in Lincolnshire, in the County Hospital at Lincoln. And my experience of utilising the hospital is that it's not a particularly user-friendly one for the patients concerned, the customers or people visiting patients in the hospital. And it's really more really more considered in relation to the staff and the staff wishes who want to work there and not necessarily travel between sites or move to lesser sites where the services aren't as interesting or comprehensive. And the second thing that worries me in relation to that is that the fundamental problems that exist in the major site that we have in Lincolnshire, which is the county hospital, and the access to services and particularly the access to the emergency services. We had a good example there from Councillor Wotton about how long he had to wait to actually get into the system. Don't seem to be addressed. We don't seem to be addressing the problems before we almost add problems to the problems. And that does worry me a bit because there are fundamental issues, I think, within the health service, and particularly in Lincolnshire, that need addressing. And we don't seem to be, really dealing with those. And everything that I seem to see, well, not everything, but a lot of what I seem to see coming out of the reports that we've got will seem to add to those problems.
Thank you, Councillor Allen. We've got Councillor Parkin next, please.
Thank you, Chairman. Ray, can I just say welcome back? And it's lovely to see you back, and it's super to see you recovering well, despite the experience, it really is. Can I just say, I think the actual package of documentation that we've got is incredible. It's incredibly well detailed, incredibly well structured. I think sometimes a little bit repetitive. I did sometimes feel I was, and I think in terms of ease of use for us as a committee, I think we probably didn't need all of it. But I'd rather have all of it than feel that we've not had enough. And I think there's lessons learned, I think, for us corporately about what a public consultation and its evaluation looks like. So well done for that. I think I'm really interested in Linda's comment about travel and transport. I think therein lies the rub in terms of how successful these changes are on a long-term basis, and I'm really interested to hear about what that collaboration, as Linda said, looks like with us on that. Have we got some synergy between the Highways Committee and Transport and these changes? You know, what are those discussions looking like moving forward? I agree that the staffing, where we are now in terms of Grantham, and I have a huge amount of sympathy, as I've said before, with the situation there and the campaigners' points there, but I still can't see another way around it that gets us through the staffing issues. And what we do have, and I don't want this to be taken as a part of political observation, because I'm here as an independent, but we have to have, as a committee, a proper and open challenge and dialogue with government about what is going on in the health service, because it is quite clear that what we are doing at the moment in Lincolnshire is replicated countrywide, in that we are doing the best job, I believe we are doing, and the NHS and the CCGs are doing the best job they can with what is almost an untenable situation from central government. And I would be saying that whether it was a Conservative government, a Labour government or whatever. It is years and years of problems in the making. And I'm not sure that we're actually having a broad and an honest dialogue about that for the long term. So I'm interested in comments on that. It's encouraging to see real positivity about the staffing issues coming through. However, I think we need to keep an eye on that as a committee and be ever mindful that that can change on a pin. And huge concerns about ambulance response times as well. Just wondering, Carl, what's our plan as a committee to kind of almost have real-time updates in terms of the situation in Lincolnshire, and be very clear as to what improvements we would want to see, and what input we can have there. Very much kind of thinking of how we move forward on this as a committee in the future. And I think the staffing and the ambulance ones really scream out to me as issues that we need to keep grasp of. And I've made this point before, and I make it particularly in reference to stroke services, and this is not to in any way cast aspersions on Ray's lifestyle or anything like that, because I can tell he's a super healthy bloke and really active guy, I know that. But so much of the pressure on the NHS, people can prevent with healthier lifestyles. And I hear that we are talking about good publicity strategies so people understand and people know what help they can get there, how to act if they suspect a stroke, all of that I get, and all the rest of it. But there's nothing in here about what we do about public health, about those front-facing, real positive forward message about lifestyle changes that we can encourage people to make. And so many of the issues that we have here could be alleviated in terms of pressure if we were clearer on what messages and on what action we could take on those preventative measures. And it's like, I know that, you know, there's leisure centre issues in South Stephen and access to those as well, and all it's just all part of that package. It's all part of it. We can't separate it.
Pete, have you got any comments on that at all?
Was that to me, Chair? So yes, so
Yeah,
I can try
was,
and
yeah.
was to
Because I think there were some questions there from Councillor
Yeah,
Parker.
yeah, that's fine. That's fine. No, thank you. So firstly, it's pleased to see Councillor Wootton back in the chamber as well, and on yesterday's chamber as well. So, and I'm pleased the stroke service you got was good, and sorry to hear about the waits in A&E. I don't think anyone thinks they're acceptable, and obviously there's a lot of work going in to address that. But I'm pleased that actually the stroke service you had and the stroke care you got has been good for you in that regard. And I think the proposals here, because there's work to be done on stroke, there's a capital business case for the stroke unit. The aim would be you wouldn't go into A&E, you would bypass that and go straight into the stroke unit. But that's a separate piece. So in terms of the questions, so the first one was around the A&E. So we've had, and it's not unique to Lincolnshire, the A&E model of many hospitals, which we had, that goes back many, many years, as services become more specialised and more concentrated, you do end up with centres like Lincoln, Boston, the ones in Nottingham, where you have a centralised service of specialist support staff for type 1 A&E. Grantham hasn't had that. So for 14 years, since 2008, the sickest people, the most acutely unwell people in the Grantham district area have been transported to other centres. So it's not new. Even at 2016, you had people who were going elsewhere, and the evidence around that, if you look at the heart centre, so Lincolnshire centralised the cardiac unit at Lincoln back in 2013. It's one of the top performing heart centres in the country, with some of the best outcomes for patients, and it's been proven to save lives. This is happened across the NHS. So major trauma came in over 10 years ago at Nottingham University Hospital, was the major trauma centre for the East Midlands. Patients in Lincolnshire who end up in a significant car crash or have major trauma are transported either via road or via air ambulance to Nottingham. That's been demonstrated to save lives. Grantham, unfortunately, is a type 3 centre, and both through a number of reviews, the independent reconfiguration panel, which the overnight closures we referred to, and the East of England Clinical Senate and the East Midlands Clinical Senate have all said it is not a type 1 A&E. It shouldn't be called an A&E because it causes issues to the public and what they can and can't be treated for at that unit. And that the biggest change here is the naming convention, because already patients are going elsewhere. Yes, there's going to be extra 700 patients, but they are made up of, if you think, the most acutely ill patients in Lincolnshire, in Grantham, are already transporting. These are adding on to that group, and it's done because there was a clinical assessment that said actually they have been looked after at Grantham. Some shouldn't have been. So the kind of acute cardio syndrome, actually it was determined they definitely need to go elsewhere. And the others looked at and say, based on their kind of news score and their frailty score, they'd be better seen somewhere else. It'd be better for them in the long run. And that's the decision that's gone into there. As a UTC, it was the East Midlands Clinical Senate during the kind of review of the proposals that said the counties, NHS county that we put there must have UTC plus, and they said no, it doesn't. It's not a naming convention that anyone knows of. It leads to confusion. It was through that was dropped. But the UTC that is proposed or that will be implemented at Grantham Hospital is far significant to most UTCs up and down the country. It has middle grade doctors as part of the rota. It has a consultant oversight for a number of hours because obviously they need their training. It has acute medicine, community medicine bed that actually they can refer people into. So it's not like your standalone UTCs, nurse-led with GPs. It has a full kind of range of expertise. It'll also bring back 24/7 access to Grantham. So I look at that, and if you're having an issue in the middle of the night, members of the public can actually go to the UTC, be seen, and be treated and get home rather than having to go elsewhere. Of the 700 patients that we expect to be moved to other centres, they would largely be transported by the ambulance service, so that we wouldn't necessarily expect them to be transported by themselves. And the protocol will be, we have to get it right. So once it gets implemented, we have to be clear on what you can and can't go to a UTC. But the public obviously know that anyway, because they understand in certain areas we can go to Skegness or Louth UTC or to A&E at Lincoln or Boston, or they know that. But it's about, we still need to be mindful of that, and we need a strong kind of messaging to understand that. But largely it'd be the ambulance service who will determine, based on news scores and frailty scores, or what the kind of condition is, and they will transport the patient to the other centres in line with the kind of current pathways that we have in place. But that doesn't get over the transport piece that Councillor Woodson raised in terms of we've had engagement with the county council as part of the discussions around the decision-making business case. You can only take them so far, otherwise we'd be prejudging the decision of the CCG board, along with the stage for implementation. But clearly what came out of this, and it was in the board paper, in terms of regardless of what happens to this, transport across all all services is something that we need to look at, and we need to look at together. So the aim is to continue that dialogue with the county council. How can we get the voluntary services stronger? There will be elements where we will increase our commission of EMAS. There'll be elements where we commission our patient transport services as well. But there are kind of national stipulations around what you can and can't do in that. So we are going to carry on to work with them. But in terms of the proposal for who provides the UTC, we're going through the current stage at the moment. So determine then, if now we've made the decision, what are the procurement options? If we have to have an extended procurement, that would extend the timelines for putting the UTC in. If we can reduce that down, because when the temporary change happened, it was emergency change, so the procurement didn't come into it. So we need to determine what that needs to look like. I can't prejudge that, but as somebody, you'd want hopefully it to be local services, an integrated model between LCHS and ULHT. But we'll have to determine what procurement options are, and then run a kind of fair and open, transparent process as we go through that. But I think the aim would be to have an integrated model there with ULHT as we go through. But the other question then came through around specialist services, which I've kind of touched on. But patients unfortunately do travel, because it's the nature of having, you can't have specialised skilled clinicians and resources everywhere. That's just the nature of it. So up and down, so best practice national kind of policy is to centralise those skills and expertise to best kind of serve the greater population. And the feedback we had through all the clinical discussions were, yes, the sooner you can get seen by anyone, doesn't matter what, the sooner you can get treated the better. Actually, in the balance of risk, the outcomes for seeing a specialist service with the right skills, expertise, equipment far outweighs any kind of increase in travel in terms of doing that. And what we're doing here is, yes, we're moving stroke to Lincoln County. We're actually opening up Grantham to 24/7, so that will actually allow people to be seen there during the evenings. That should support. It will support Lincoln County and Boston in that respect. The new model for acute beds will allow repatriation back to Grantham and allow kind of support for elderly patients in the local area and be repatriated back to their place of residence. And orthopaedics, the whole aim of orthopaedics is to take it off those major acute sites, so elective orthopaedics can take place, ring fenced away from that, so it isn't impacted, because the previous model was everything was done everywhere, and therefore we had a high rate of cancellation. So part of that specialised move is to move it away from that. There are, I think, the question around addressing problems in the NHS is under pressure. You don't need me to tell you that. It's up and down the country in terms of the pressures on ambulance services and emergency departments and general practice across the piece. We do need to, I would argue, there is a need to look at that nationally in terms of where we go to. I think locally, though, we've taken steps to address that. The medical school in Lincoln is going to be really, really helpful to attract the skilled kind of clinicians for the future, as is the work in the kind of the academy that we have in terms of apprenticeship schemes coming through to grow our own. Lincolnshire has excellent schools. We need to keep those school-aged children staying in Lincolnshire to have their education, to go to the medical school, to be trained up and work in our local hospitals or general practice or how the new future models of care will be. And I think that's a great step. And as that grows and can turn United Lincolnshire into a teaching hospital, that all attracts people to come and work there. The joint links will also attract to have kind of skilled professoralships and bring research into the county, which is all a benefit. And I think that's some of the local steps taken to try and address those issues. And then the bits on stroke services and health inequalities. So there is work taking place with public health now, because you're right, this will treat the patients, and we'll still need to treat the patient because people will still have strokes. But actually, we do need to address the health inequalities, the population health, the preventative measures, and there is work underway across the integrated care system, so with the voluntary sector, the county council, general practice, CCGs, to say, right, how do we address that? How do we make people look after, have healthier lifestyles? But there needs to be a range of offers that go through. So but that work is underway at the moment in time, and it's something that we will continue to progress. And certainly as we move into the integrated care system, that's one of the key benefits, is that preventative measure, so people don't get ill. We better if actually we did look after ourselves, and you didn't need health services, not because of the NHS, but actually just as individuals and for our own benefits, really, in that regard. So I think I've answered all the questions. If I missed anything, please please let me know.
Thank you. I've got a long list of speakers that's come in, so I've just got a question myself quickly now, and that is something that makes me incredibly nervous is the fact that we're talking about access to the UTC at Grantham as it will be 24/7. Now, I think everyone in this chamber would welcome the return to access of primary care overnight. However, we can look at Skegness only a matter of months ago that had to close because they couldn't staff it. And then yesterday or the night before, I believe, Louth Hospital had to close overnight because it couldn't be staffed. So how can you reassure us that you're going to be able to resolve the problems there within Grantham and that it will remain 24/7 and that we don't find ourselves in a position where, again, it shuts overnight?
No, so the key to this is, so as part of the work, we worked with both ULHT and LCHS, and as you see in the report, there's kind of statements of support that they say they can staff this. And I think the only way I can look at this evidentially around Grantham UTC is the actual the green site temporary change, where it maintained the 24/7 service throughout that period. The fact it'll be an integrated service and with inpatient beds as well, so it has mid-grades doctors involved, will support that process going forward. I acknowledge the issues at Louth and Skegness, but in this one, the nature of kind of skilled staff that's not just provided by the community provider will enable that, and has demonstrated to enable that, to keep it open 24/7.
Okay, thank you. I've got Councillor Loughagan next, please.
Thank you, Chair. I'm going to ask a very brief question. I'd like to express my sympathy with the concerns expressed by some of the other councillors in the chamber. But I'm fairly new to this committee, so my question is very straightforward. The information you sent out on the consultation is incredibly detailed, and I've been through it. But could you tell me what changes you have made, what fundamental changes you have made to your original plan as a result of that consultation? Thank you.
Yeah, so in terms of the 4 proposals we went to the public on, there was no alternative proposals that came forward. There were suggestions in terms of when we implement it that we'll look at, and they're captured, but there was no alternative proposal. The alternatives were, we wanted a type 1 A&E at Grantham Hospital, and that's been explored, as you can see in the supporting paperwork, and on why that isn't feasible. The other alternative was around, right, stroke's fine, but actually why don't you have it at Boston Hospital? And there's work that clinical evidence that says why the reason it's Lincoln is the co-location with the cardiac centre, and also the kind of the pathway into mechanical thrombectomy in Nottingham in that regard. But there wasn't anything that came out, there wasn't any proposal that came out that changed what we put to the public. And I think the key there is we did the pre-consultation engagement through the healthy conversations, and also the detailed clinical work into coming up with a model that the clinicians, both in and out the county, fully supported and backed. And therefore it was then to test them and see, is there any risk, any kind of considerations we need to look at to make sure they were robust. But during healthy conversations, I think the original proposal around Grantham was for it to be, wouldn't be open access overnight, for example. And part of the reason that pre-consultation was to say, when we put the final proposals to the public, we're taking on board those early kind of considerations. And therefore, when we went to the public in September, UTC was going to be a 24/7 open access service, so that it already kind of incorporated that through our kind of early engagement rather than just through the public consultation.
Okay, thank you. I've got Councillor Smith next, please.
Thank you, Chairman. Bear with me while there's a couple of things, Chairman. In terms of staffing, for as long as I've been in Lincolnshire, and it's a long time now because I came here when I was in my last year of primary school, so that tells you how long. Staffing has always been a systemic problem. This is not a new problem. This is not something that's crept up on us. This problem has gradually deteriorated over the years. So to be blunt, Chairman, yes, there's competition for these trained staff nationally, and I know how long it takes to train these staff, but ultimately there has to be a question of, when did things start to be looked into? When did we start to do things at an NHS level and go, oh, we've got a major problem here, you know, we're going to be caught with our proverbial pants down, pardon the expression. In terms of ambulance times, I always remember this story. I went to see Case to Fire Service, and that they had been at an RTC, managed to get the person out of the vehicle. They were then with this person for 3 hours. and he was not life, but he was serious, but he was stable, or she was stable, but they have no pain relief. They're not medics. They can't give the sort of pain relief you need. It also tied them up for 3 hours. So had there been another fire nearby, they wouldn't have been able to use their assets to do their day job. They're also actually being asked to do more as a fire service in a more health-centric role, which they say they can do. But from my perspective, I'm probably a bit old-fashioned in that sense that I believe in, as a health service, that is what an ambulance is for, and a fire service is what putting out fires and protection and preventative, and so that concerns me that they're being asked to increasingly pick up some of that burden. In terms of centralisation, I can understand the justification for it. I don't agree with it, I'll be honest, Chairman, because you will get to a point where we are as projected to grow continually in the next 20 years because we've been told to take more properties, more houses. What happens if the sites are mothballed? It takes a lot of money to restart a hospital site, which is why the dedicated military hospitals in this country were closed in 2007, because they were not kept up to scratch. They were old equipment, they'd been left, they hadn't been kept up. So there is I have a real concern that eventually you will start losing some of these urgent treatment centres, whether it be Grantham, whether it be Louth, whether it be other patches. In terms of transport, Chairman, people are going to have, it's getting to the point now where people are going to have to go, can I afford to go to this appointment in hospital or not? To fill, I had half a tank, to fill my car cost me £65, and I have a very small engine in my vehicle. That was with half a tank, so you can imagine it's probably going to cost, the average family car now costs over £100 to fill. We at the County Council, in comparison to the NHS, I'll be blunt, we actually are quite poor financially. We cannot be left holding the proverbial baby for transport, because if we are, we're going to have some major government funding changes, and if that doesn't happen, we're going to have to be honest with people and say, look, we can't fund this, we do not have the money to do this. In terms of Councillor Parkin's point in central government, it's not a party point, she's quite right, it has been an issue of all parties, certainly in my lifetime, but I'll be blunt, Chairman, that certainly in the last 20 years, health spending was protected when actually other departments got slashed. Local government, for one, defence. I could name a list for here to eon. There actually needs to be a look back at oneself, and actually, there's got to be wastage somewhere. We can't be spending all that money properly. I'm not saying a majority of it is, of course it isn't, but there's obviously things that can be changed, reformed, so that funding gets to where it needs to go, which is on the front line, whether it's your hospitals, your GPs, whatever. Because the current situation of continually centralising things in Lincoln at such a large rural county isn't sustainable, Chairman, least of all clinical reasons, but the simple reason of try parking there. If you're visiting or you're a non-urgent patient but you need to have an appointment, especially if you're disabled like myself, it's potluck if you can park somewhere without killing yourself before you even get to the front door physically. We're going to have major issues, Chairman, if things don't change, and I can't, from this and other documents we've seen, I can see change, but not the change in the right direction, unfortunately, Chairman. So I think we need to have a frank and honest conversation amongst ourselves to lobby government, and then have a frank conversation with our NHS colleagues. Thank you.
Thank you, Councillor Smith. I've got Councillor Rice-Ockley now, please.
Thank you, Chairman. Thank you for having me today. I'm here in place of Councillor Mark Whittington, who has a Grantham ward, and I have a Grantham ward, and I live in the town myself. Fascinating discussion. Yes, it was an incredibly long, was it 400 pages? It's probably the longest one I've had. I think we all recognise here that 24-hour emergency healthcare is absolutely vital for Grantham and the surrounding area. Echo your comments. A daytime A&E with a GP surgery overnight is not appropriate for a town, an area of this size. Almost everybody you speak to in Grantham has an anecdote, or they know somebody who has an anecdote about not being able to get A&E emergency healthcare when they need it. My own anecdote is that we were blue lighted with a feverish and hallucinating toddler a few years ago all the way down to Peterborough. Incredibly long, stressful journey. Turned out to be tonsillitis. Could have been fixed incredibly easily. We felt really bad afterwards. We'd put an ambulance, we'd taken an ambulance, out of circulation when it could have been doing something more important. So it's really, really important I second your comments. It must be 24-hour, it must be permanent. We did raise at Southcare yesterday the issue about transport. People have spoken about that. I won't go into that again, but just to say that, so on page 269, the issues have been recognised. There's a lot of mitigations here, but there's a lot of different organisations mentioned. And I think going forward, the concern would be that patients, these 600-700 patients extra who are going to need transport, the concern would be, are they going to fall between stools? There's various organisations. How is this going to be monitored going forward, both at the time of change, but also, over time, how is this monitored? And also, who is going to be ultimately responsible for this transport strategy, particularly for ensuring that patients in the disadvantaged groups have the info, the access to the transport that they need, both emergency and non-emergency. I'd also like to refer, please, to page 121, and Councillor Linda Wooten referred to this, when it says it's about a change in nomenclature and communication with the public being key. Councillors Wooten and Wooten have spoken about we have a large number of very concerned people in Grantham. Our residents are very concerned about this. The results of the consultation show that the battle for hearts and minds on this, I'd say, is very much in its infancy. There's a lot of communication needs to go on. If this goes ahead, what's the comms strategy here? How is it going to be resourced? Because this isn't a short-term thing. This is going to need to be a communication strategy over months and years. And what does success look like in terms of those communications? We need to return to a time when the residents of Grantham feel safe and secure and looked after by the NHS. We've heard about the full, it sounds great, full range of emergency care and more significant UTC than your average UTC. I listened to all that. It sounds great, but the message that message is not coming through, and I think people are concerned. It then becomes a mental health concern, because if people are worried about healthcare for themselves and their family, that's an additional worry for people, and we're in a worrying world at the moment. So it'd be good if this could be sorted out, and if the communications, as I say, it could be properly resourced for a long term, so that people feel safe and looked after. Thank you very much.
Thank you. Pete, would you like to respond to that, please?
Yeah, thank you, Chair. So there's a few different topics in there. So the fire service, so the wait, so ambulance, I'm not an expert, I'm not here to represent the ambulance service and the waits. There's a national, I don't think any of the chief execs nationally would say they're in the place they'd want to be. They've publicised that. Waits are too long to be seen by an ambulance. That is definitely known. So and that's something that we are working on nationally, trying to rectify that issue. But in terms of the fire service, that's not unique to Lincolnshire. I know in the East Midlands, the fire service reached out to the ambulance service to provide kind of community response services to it. The wait there described is excessive, no doubt. But in terms of that's what they've looked to do. But in terms of some of the other questions around then, in terms of growth, so the NHS funding has been protected. I think, but if you look at the growth, the funding has been protected. The actual level of activity isn't protected, and it outstrips the growth in funding. That's the same. The councils hasn't even been protected, and you'll know that your own services has increased. So I'm not asking for sympathy on that one, but that's the case we find ourselves in, and you can see that through the how many people are accessing urgent and emergency care up and down the country is at record levels in terms of doing that. So trying to manage that growth is a key issue, and hence having stuff like, and in terms of then the workforce planning, that is something that is picked up by Health Education England, which will in the new world after July will be part of NHS England. That in terms of sponsoring deanery placements, nursing placements in hospital, that's what they plan for in the long term, and we input into that. But it's a national kind of consideration, national funding that goes around those growth. The key for us is to work with schools, work with the local communities, and work with the medical schools to attract people to come and work in Lincoln and stay in Lincoln. But it also goes to, if we can attract people into Lincoln, it's about embedding them into, so we get their children into the good schools, we get them living in the county, so they're not locums driving in and driving out in that regard, and making sure that we can embed them and keep them in the county, and then grow those services. And that's the key for the medical schools, key for the work with the colleges in terms of attracting people through. It's the key to the opening of kind of the nurse and the postgraduate school at Boston to have that kind of level of training and skills and qualifications as we go through. Transport, as I said, is a key factor that flows into this. So in the emergency cases, so the Grantham 700 patients, and also the stroke patients, they will access the other sides through, as described there with the paediatric case, through an ambulance transfer into those sites. So it wouldn't be public transport. But if you look at the figures across the county, it is a rural county. So prior to any changes, and as described yesterday, 15,000 patients a year from Grantham already go to other centres. 25,000 patients, I believe it is, in the county already travel 45 minutes to a hospital, and it is trying to get that balance right. So yes, there is a balance of crowded hospitals, but there is only so many stroke consultants, for example. There's a national shortage on stroke consultants. To have the right stroke care and this is the clinical evidence, this is based on all the clinical reviews, you need a concentrated stroke team to get people back on their feet, back home. The evidence, even the temporary change at Grantham, at Lincoln County, has demonstrated actually, even though people travel a bit further, they get seen quicker and have a stroke review quicker. As they go through, their length of stay in the hospital is better. The actual census bucked the trend when they did the kind of snap audit on it back in 2021. None of the hospitals in the country had hit all 10 markers of the snap audit. Only one hit 9, and I think it's 5 off the top of my head hit 8, one being Lincoln County, and that's when it's centralised and it's still a pressurised model. We need to make this permanent. We need to then build the staffing model around it. We need to increase the consultants that are based there and improve that care. The cardiac centre demonstrates that's the right thing, and the right approach. But we do need to work collectively on transport. I'm not saying it's the councils should pick it. We need to work collectively, because transport in a rural area, as demonstrated before these changes, is something that we need to work on to try and improve and make sure patients don't not have access because of the cost. We do need to work on that, but there are kind of criteria that we all work through as we go through that. And in terms of the comms around UTC, yes, I don't disagree at all, and that's clear in the business case that is something that we'll need to do as we go into the implementation stage and beyond. In terms of that. In terms of local hearts and minds, it depends on what you say. So if we look at this, the questionnaire survey, yes, there's slightly more against it. But if you look at the resident survey, which is a more kind of representation of the population, there's still over 70% support for having a UTC. And being at the Grantham events, you do have the people who are massively opposed to it. But then they ask the question at the meeting, is anyone for this? And there's people putting their hands up, think, yeah, that's a good model. I want 24/7 urgent treatment care, urgent centre care. But we do need to communicate and make sure the public are aware what they can and can't go there for. And I think largely that will be, actually, if you call an ambulance, that's when you're going to need to be taken elsewhere. But we need to make sure that's specific as we go through. But what doesn't help is, in the public press, you read in the press, 70 beds are closing, and that's getting pushed out. That's not true. We're changing the model around those 70 beds, so it'd be an integrated community and acute medicine bed. So the beds would still be there. We're not shutting those patients, saying 700 patients are at risk in the die, when actually already we transport 15,000 patients out because it's better for their care, and we're adding to the kind of the lower end of that acuity. Doesn't help the message in that sense, because then you get one-sided, and we need to understand, and we need to continue as we go through this, work with the public on that model, that care, what it means, and what you'll get at Grantham UTC. And that's something we will continue to do, and work with you as a committee as we propose, as we go through the implementation stage of these proposals.
Thank you. I have to say, having done the quality accounts for EMAS not so long ago, and having looked at the ambulance response programme, they are not achieving any of their targets now without additional pressure on them. So that's a major concern for me, that this is going to be added on and we are going to end up with people that die because they are not taken to our hospitals in a timely manner. I'm also incredibly concerned with your transport side of planning as well, because we know that the non-emergency patient transport service has rarely ever achieved any of its KPIs. So how confident are you that this is a viable option in transporting patients?
Yeah, so there's a wider issue with the ambulance service, and I think we acknowledge that, that's looking at that. If you look at the stroke transport data, the average increase in travel time is just over 20 minutes from if you went to Boston, if you go there. But the actual average travel, the actual time to be seen by a stroke consultant reduces it's around 56 minutes. So although there's an increased time, you're seen quicker and you're treated quicker. And that's the key there, is going to the right centre for kind of working on that. Is crucial. Sorry, Carl, I forgot your second. Oh, the PTS. So we have gone out, as you know, we went out for a procurement for PTS. In the business case, there was £1 million included in there for additional travel support. Some of that will go to EMAS, and some of that will certainly go to the patient transport service, which will be taken over by the East Midlands Ambulance Service after the Thames contract comes to an end. And there's already those discussions around the increase in terms of provision that they will need to put on, and the increased contracting value that will go to support that. But I'm not sitting here and say there aren't pressures in terms of doing that. But the stroke pilot, which has been the stroke temporary changes, which has been in place since April 2020, has demonstrated actually the outcomes for those stroke patients. Although there's everyone's concerns around the ambulance wait, but they get home quicker, they are seen quicker, and therefore their outcomes are better. We need to improve that. I'm not saying we don't certainly do, and my colleagues from EMAS would agree that they'd want to see those times rapidly improve. But actually the clinical evidence is that actually the care they get from the stroke center, for example, is better than it was prior to COVID.
Thank you, and I understand what you've said there, but the problem is it doesn't matter if it's only 20 minutes longer, it's the 6 hours they have to wait prior to that 20 minutes. Okay, I have my next speaker, that's Dr. Wookey, please.
Thank you, Chairman. I'll be brief. I know you've got a long agenda ahead of you. Just two things. The first is to explain that as far as Health Watch is concerned, we are a county-wide body, and we did have a debate about whether we should actually make specific comments on each of the 4 issues. And I think it was felt that really the elected members for those different parts of Lincolnshire are the people to do that. And we have concentrated on the process of the consultation and have gone to considerable amount of time and effort in satisfying ourselves that the process has been thorough and it has been satisfactory. And so it should when it runs to over 1,000 pages. So that was just to put things in context. The second issue, which has come up several times, is that in the emergency departments, and somehow or other we've got to get the nomenclature right, and I think it's going to take years to get rid of A&E as a actual, nobody quite knows what A&E is now. But in the emergency departments, there is supposed to be a UTC in front of the departments at Lincoln and Boston. And the impression that we're getting from reports is that actually it isn't a separate department which deals with things which can perhaps or should have been dealt with in primary care. All it is somebody asks you a couple of questions at the desk and decides whether you want to see X doctor or Y doctor, and perhaps a little bit more than that. So I'm not sure that going to some trouble and expense with the UTCs in front of the major departments actually has made that much difference. But I'd be interested to know what the outcome is supposed to be. And the second thing is I was concerned about what Councillor Wootton told us about the wait he had, which seemed to be absolutely horrendous. Obviously, there are strokes and strokes, but that takes me back to a time, and I don't see why we can't look at this again. I mean, at the moment, the emergency department is like a three-way dual carriageway going down to a single lane and then expanding a bit after a long wait. In most of my professional time as a GP, if you had somebody who had a serious condition of that sort and you were aware of it, or an abdominal pain or a chest infection, you didn't send them to A&E, you rang up the appropriate department of the hospital and spoke to the junior doctor there and told him that you were admitting a patient. You didn't have an argument about it. You'd made an assessment and you were admitting that patient. If the argument went on, then personally I would ring the consultant and speak to him. So although I know there could still be a bottleneck, I think that sort of process ought to be looked at again, and certainly in Councillor Wotton's case, and I'm sure there are many more, as you know, at Skegness and elsewhere, that could be mitigated, that at least you were seen by somebody in the specialist unit who could make a decision as to whether immediate action was needed or not. With all due respect to A&D, the senior members of the A&D department can't be everywhere, and it's often somebody who's relatively junior, and the GP probably, if they're doing their job properly, and I think they've got to look at their position with this, is to make a decision and go for it. It's no good a receptionist saying going to A&E. You've got to do better than that. Even a quick phone call with a GP will give them some idea of whether they need to be admitted or not. Thank you.
Thank you, Dr. Wookey. Pete, do you want to come in on that, please?
Yeah, I'll be brief. So one, I'd like to thank the committee's feedback on the consultation, the process, it being thorough. All I'd say on that is that thoroughness also works into the clinical models that sit behind the proposals and the in-depth clinical discussion that's come up to where to the decision that was made or the proposals put to the CCG board. That thoroughness isn't just on the consultation, it's paramount to everything that took place. In regards to that, I'm not qualified. I'm not an expert in terms of, I have an understanding of how A&Es work. The UTC's on the front door. I don't know the model in terms of how, but I know full well, speaking to colleagues in LCHS on Friday, because I'm currently the CCG Golden Core, and I understand the pressures taking place this week, that actually they are vastly kind of required, both at both ED departments in terms of the nature of patients coming through that way. But in terms of A&E waits, and direct access to pathways, I'm not clinically skilled enough to get. I understand the sense of it. I am aware of that taking place in other areas, in other trusts I've worked in, but I think you need to raise that with ULHT. The one thing I'd say on the stroke one, I mean, Councillor Witten's wait was far too long, is the stroke proposal would, once fully implemented, should allow direct access to stroke. So you wouldn't go through A&E. The ambulance, what the protocol they worked on is that the crews should work with the advanced care practitioners in the stroke unit, and you'd get straight in. Hence, the evidence through the temporary change is that actually the review from a stroke clinician has improved because they are having that direct access. But it isn't a standalone unit with the increased beds that it needs to be at the moment. When it is fully implemented, that should improve that pathway. But on the other bits, that's an operational kind of clinical discussion, I'd say, with ULHT, I'm afraid.
Thank you for that. I've got Councillor Cleaver next, please.
Thank you. Coming back to the question of Grantham, I noticed that in figure 30 on page 215 of our agenda pack, there is a figure quoted for population increase in Grantham, and it states that the population of Grantham is planned to grow by less than 7,000 people between 2016 and 2039. I find that rather surprising because the South Stephen local plan shows that 7,500 new homes will be built in Grantham between 2019 and 2036. Now that equates to at least 15,000 new people at 2 persons per household. I believe actually it's more than 2 persons per household is the average. And that concerns me greatly because you're planning these changes to Grantham on a population growth which is actually half of what it's going to be. So my first question is, can you check these figures and can you review this, or is it too late to do that? My second question relates to the figure that shocked me, to be honest, that 21,500 Lincolnshire patients travel over 45 minutes to A&E, and that we're now adding a further 750 to that total. What is the CCG's view as to what the acceptable level is in terms of this travel over 45 minutes, please? So if you could answer both those questions, I'd be grateful. Thank you.
Yeah, I'm happy to. So the growth was taken from growth plans and ONS projections on growth. Even if you factor in 15,000 though, at Grantham, the local district population is nowhere near the 300,000 level required for a type 1 A&E. It doesn't change, it's still below what you'd need. It still doesn't change the modelling in that regard. Obviously it is modelling going forward, and these models are paced over a 5-year criteria anyway. So if the population did grow, you assess your needs. You can't plan now for 2039 though, and you wouldn't expect to see in terms of having a workforce and a model in place over the next couple of years for a projection of future dates. But 15,000 still wouldn't change that model. It's still not a growth level that would kind of mean the actual service provision that we're putting in would be any different at this stage. But it's obviously something we'll assess and take forward going forward. In terms to the level of 20,000, that was a figure quoted on where people reside within Lincolnshire and how far it is to travel via car to each area. And that is, that's just geography. That's just where they live in their communities, how far away their houses, how far away their villages to a local centre, emergency centre in that regard. If you look at the most severe pieces, cardiac centre is demonstrated to improve lives, major trauma at Nottingham is demonstrated to improve lives. Obviously time is of importance, but there isn't enough level. There's two things: there isn't enough clinical specialist staff, there isn't the money to have more A&Es across the county, so that travel time reduces. There isn't the workforce out there, and there isn't the funding to support it. But even if there was, those centres wouldn't have enough activity to maintain their clinical skill set. So there's that balance, and the key for this and through that clinical kind of review is the balance is the extra travel actually is far outweighed by the improvements in outcomes and the improvement in their long-term kind of prognosis and getting them back onto their feet. And that's not me saying that, because I'm not a clinician. It's all the clinical assessments that have taken place. That's also national policy. It's also national best practice, centralised skills. And so that's what we're trying to do, because that travel time is one aspect, but actually having the right skilled clinicians, right expertise, right teams based around them. And it isn't, healthcare is done in teams. It isn't done by one individual specialty. They're done collectively. Having those concentration, those right skills will lead to your better outcome and will get you back home quicker, get you back on your feet, to have kind of back to the lifestyle you had previously, or as close to it as possible, depending on your condition. So that's why it's done like that. It's not unique to Lincoln in that regard, but the travel time is an aspect of where people live in terms of how close their local A&E is.
Can I just come back on the question of the population growth, because it does concern me a lot. That's a major difference, a very major difference. 15,000 people is a lot of people. I accept what you say, that under the rules, that may not trigger any change to the policy that you've just bringing about, but it does surely have an effect on the plan of the level of provision at Grantham Hospital in terms of the volume that you're budgeting for. And it concerns me that CCG has not taken that into account. So in terms of that's a growth projection of over, well, certainly 17 years from now, and we'll assess the growth of the services as you move through. But there's a critical mass of services. It's not like if that increases, suddenly you need to increase your workload going through that department, or increase your staffing levels. The key there is the provision. Even with that 15%, if it's 15,000, should I say, growth, it doesn't change the service model that's taken in place. And as it organically grows over time,
as it will do, because it's not just Grantham that's going to have a housing growth. Across the country there'll be housing growth, and the NHS will need to take that into account across all its kind of areas of care, not just in both in primary care, secondary care, community services. And we'll need to take that. It's not just located in Grantham where that's happening in that regard. But in terms of this figure over the next 5 years, that growth rate won't change the service model and the level of activity as we go through each year when we do a planning round. So at the moment we're going through it, we'll do a detailed planning assessment of terms of level of activity and afford the funding that goes and the kind of service model that goes with that. So no, I understand there's a difference in that. It's modelling. It depends on where you take the modelling from. That was the figure we looked at, all the kind of information we had available to us. But even if you say, right, it's 15,000 growth, it doesn't change the service model that we're putting in place, because it's nowhere near the kind of critical mass to have that kind of step change in service.
Okay, thank you. I've got Councillor Chalmers next.
Thank you. Quite a lot of what I've got to say probably mirrors in a slightly different way what other people have said here. I've got massive concerns, as Councillor Wooden did, with the stroke care available, certainly in Pilgrim. And I've got a very similar story. My mother-in-law spent 20 hours in Pilgrim Hospital waiting for an ambulance to transfer her to Lincoln to receive the better outcome that has been spoken about today, for it then to be deemed that that ambulance was never going to come. And she was then, at that point, admitted into Boston because the ambulance service had failed. And then again, sorry, I can't see your name tag. You said that there's currently 21,500 Lincolnshire patients travelling, and it was said by car. So again, we're looking at the increase in an already failing ambulance service, failing to provide care to our greater community, putting extra pressure on the A&Es that are already existing, waiting for transport services to get you to that specialist care. So my question is, if this is the situation now, if the transport creates a failure of your new system working, what KPIs or higher limits have you put in place to say, right, well, this is a failure and we're going to revert back to the old system? Thank you.
So the key there, it will be monitored, but the key there isn't the old system isn't the right for patient outcomes. So if you look at national best practice for a stroke unit to have 650 patients just to keep the stroke skills up, we don't have that. So Boston, even with projected growth, takes it under 500 to 550. It's currently around 500 stroke patients a day would have gone to Boston a year, should I say, would have gone to Boston. So it isn't at the critical mass of having that. That it isn't co-located with cardiology. And if you look at strokes, 25% of strokes come from a cardiac complaint. So that co-location with cardiology at Lincoln County is crucial. The pathway into mechanical thrombectomy and nostrum is a critical path. And if you see the rate since that change from Boston to Lincoln through COVID, has increased the rates of patients getting mechanical thrombectomy, which is the clear kind of specialised procedure that you need if you can't have thrombolytic drugs because you're pregnant or you've got an underlying health condition that doesn't allow that, and that really does save lives. So the key here isn't about saying, well, we'll have it. Having what is deemed a stroke service closer, which hasn't got the skills, expertise, and the clinical support around it, won't lead to better outcomes. The key we need to do is work on the ambulance handover times and work with the ambulance service to improve that. I think we'd all agree with that. Everyone across the NHS would agree with that. EMAS would agree with that. We need to increase or reduce their kind of travel times in terms of their job cycle times, their waits, so actually they can respond properly. That's the measure we need to be looking at, not saying, well, actually revert stroke. No, we need to put more effort into improving that.
In last month's meeting, it was brought up by Councillor Boston that the conversation around the ambulance service failure has been going on for 10 years. So again, where is there a limit as to it's not working? We need to look at something else.
So I think that's more of a question around ambulance service where it isn't working than because the stroke service, the evidence shows that as a service is working. It's the same with the cardiac service. No, that is I think it's the top 5 cardiac centres in the country in terms of outcomes and lives saved and all the measures they have in that. We wouldn't want to revert that back. What we need to do is improve the ambulance service. The current level of ambulance waits, which is a national issue, is beyond anything anyone's ever seen. We need to address that problem. That's the problem we need to address it, because it isn't just a stroke service. If we move stroke back and split it, say, well, that's what we need to do. We either do that on all services, because it's not just, there's only, thankfully, of all the jobs they respond to in Lincolnshire, there's around 1,200 strokes a year. Actually, those waits are for other complaints, and we need to address the wait for ambulance and the demand on ambulance services, so actually patients can access care elsewhere if that's the right model, or there's enough ambulance provision. That's what we need to do. I think the level of the 10-year piece around Lincoln Ambulance Service as part of EMAS is the past 12 months where it's been such a significant level, which is mirrored nationally, that does need addressing. But that's the key, is addressing that problem of ambulance delays being seen and therefore being responded to as a member of the public. That is crucial. If you move straight back, it isn't going to solve that problem. It isn't going to make that any better in terms of ambulance wait. What we need to do is tackle that ambulance wait.
Okay, thank you. I've got Councillor Wootton and Councillor Smith who'd like to come back, but before I bring them in, I've just got a couple of questions myself. So my first question is, on page 98 of our pack, summaries the key consultation findings and states a majority of respondents living nearest to Grantham disagreed with the proposals for the Grantham UTC, and a majority of the respondents living near to Boston disagreed with the proposal for stroke services. However, these two changes were supported across Lincolnshire as a whole. Surely the views of those living closest to a service change should have more impact, as they are the most affected, and what is being done to mitigate this, and was their feedback worth their time?
So I think the key with all the consultation work is, as we said at the start, there's two elements to this. The questionnaires shows the questionnaire response, which is questionnaires aren't necessarily a representation of the public view. They're those who are keen and passionate about those services. That's the results from them. If you look at the resident survey, which is more of a kind of like a poll, like an elective poll, where it's kind of more consistently relevant, there was support for both of them. You can't dismiss either of them in that sense, but it's wrong to say that one is just everyone was against it, because actually the resident survey, although there was some concern and more than the other proposals, they were supported in that sense, and you have to take them both on board. Of course, their views were required, and I'm not dismissing some of those concerns in terms of the travel and transport and what that means, but I can only base on the clinical judgment that we had in terms of when we reviewed all the information that came through. So when they looked at, some of the most kind of passionate campaigners around stroke was actually they wanted it at Boston, not at Lincoln. And actually look at the clinical evidence and say, the clinicians look at the clinical evidence, say that the co-location of cardiology is critical to that stroke centre. The cardiology and the heart centre are based at Lincoln County. So we hear and understand the passion for it, but actually that you can't get away from that. Also, the onward pathway for mechanical thrombectomy is in Nottingham, so that if you moved it to Boston, you're extending the travel time through into Nottingham for that mechanical thrombectomy. So no, it wasn't. And the piece around Grantham was, again, a lot of those who were against it. And again, the resident surveys were there was over 70% support for the kind of resident surveys, but through the questionnaires, the feedback was we want a type 1 A&E, and you can see in our pack we looked at that in detail. It wasn't oh well, no, that's not possible. It's just not going to be happening. There's a detailed look at the growth rates, what it takes to put a type 1 A&E in, and all the measures that were required for that went into it. But stuff around communication, around what you can go to UTC, a lot of the feedback actually goes into our implementation of the service. For example, we move stroke, we need a campaign around kind of identifying stroke, the FAST positive and that kind of stuff, and making sure people are aware of stroke. The same to the council councillor who mentioned around preventative measures around our health. All this is that needs to take place. So no, their feedback was vital in that sense, but we have to balance it for the need that the stroke outcomes will benefit the clinicians, and the evidence from the temporary change will benefit patients across the county. And that's what we're here to kind of commission services for patients across the county. It will increase the benefit their outcomes. It's shown through the evidence through the actual temporary change, and that will improve as the service gets implemented in that regard. And I can only go by the overwhelming clinical support through every process we've gone through that say, yeah, no, we recognised some of the concerns we raised. I recognise the concerns they raised around transport and the times, but their clinical expertise says, look, the specialised centres that people get taken to will provide better outcomes, faster recovery, and get people back on their feet quicker. And I can't argue with the skilled clinicians who have done that. And it isn't just the local clinicians, it's the regional East Midlands Clinical Centre, it's the East of England Clinical Centre, the national teams through NHS England and the regional NHS England team that have done this. The LMC supported all 4 proposals. And on stroke, again, they quite rightly noted the cardiac centre. The heart, and I take this from being at the consultation events and the expertise there, the heart is a weaker organ than the brain, and the cardiac centre has proven that by centralising it in Lincoln County has saved more lives than the previous model, and it's demonstrated in where it sits nationally as a heart centre. Doing the same for stroke will again save lives across the county and be better for the population of Lincolnshire in that regard. And that's why the model's done. That's why the clinicians and the full voice of the clinicians that went to the CCG back the changes and back the proposals as they were put to them. And that's part of the reason the CCG were confident to make the decision, because it had a full weight of clinical support behind each of the 4 proposals.
Thank you. It brings me on nicely to my next question. Looking specifically at stroke services, the paper states that a third of NHS staff disagreed with the plans for centralisation. Can you elaborate on their reasons for this disagreement and what mitigations have been taken?
I can't recall going through it in terms of exactly what their disagreement was on that. Obviously, people locally, and there's certainly concerns expressed through the kind of discussions with the local stroke therapeutic teams at Boston County around kind of what it means for them. And I get that people have a service that they work at the local hospital. That's where they're based. And they have concerns because we haven't. The key to this is these are proposals. There's only so far you can have detailed discussions around what it means following a decision being made, because actually you quite rightly say if you've got detailed proposals, you've already made a decision. So what it means to them and how that service will evolve and what it means to their kind of job roles and where they'll be based. We'll go into that, and that's something we'll work with them, and United Lincolnshire Trust will work with them as we go through the kind of implementation stage of the new model.
Okay, thank you. My final question, and this has come really from Councillor Wotton's suggestion of referral, is if we do refer part of this, whether it be 2 or 3 elements of the 4 NHS services you're looking at under the ASR, will this initially have any impact on your timescale to start running this out, or will you continue on regardless and await what the outcome of the Secretary of State would be?
No, my understanding, if you make a referral, this would stop, and actually I think that would be massively detrimental to the populations that we serve in that regard. So a referral if you refer the Grantham A&E as proposed, that means it could be the length of time for those referrals to take place. I'm not sure they lead to the outcome that expected. The one around the temporary change around A&E didn't result in the A&E being reopened, and what it will delay is patients. It will delay the acute medicine and community beds being put in place, which will be better through how people repatriate back to Lincoln. It will delay 24/7 access to urgent care in the Grantham area. So that continued temporary change that people quite rightly said has been going on for too long will remain in place. In that sense, stroke service will remain fragile. They won't be able to have the sensor, so that direct access will mean that some people might go through A&E rather than going directly into stroke. And it's clear that will be detrimental to based on the clinical view, that delay will only be detrimental to the health of the population of Lincolnshire because they won't have access to these services. All I can say is the overwhelming clinical support for this is just overwhelming. There's not a single, every process were unanimously supported by the clinicians involved in that, and therefore referring it against their expertise, who are there saying that these are the right things for patient outcomes, it's the right thing for them to get back on their feet, it's faster access, it's quicker care, it's better care. If that gets referred, well, then we will wait for that referral and work to take place before that gets implemented. So Grantham will remain with no urgent access overnight. Stroke will remain an incredibly fragile service. There's 2 consultants working stroke at the moment in time. They're making these service changes permanent, confirming they're going to happen, enables those teams then to grow their staffing model because there's a certainty in what that means. It's no different to me. I'm sure it's no different to all of you sat in the chamber, that if you have certainty around kind of your working arrangements, the place you work, you can grow that model. It's difficult to kind of attract staff to a model where you might have to work across Boston and Lincoln. We're not clear yet. The service model isn't clear. It's going through a Secretary of State referral. It's again difficult to attract people into an A&E, the temporary shut A&E at Grantham, and the nursing staff and support staff when there's uncertainty around what the future model will be. Because actually, although the outcomes of those referrals understand, it doesn't really lead to the change that the referral was made on. Even if it does, they won't know that, so they'll probably go, well, I'll go and work somewhere I know that my kind of future over the next couple of years is more certain. But I think critically on that is the fact that the clinical support for this is overwhelming, and therefore it'd be disappointed if that has. It's the committee's view, and you've got your role to scrutinise and determine how best to do. But the clinicians, and based on that clinical support, will lead to a longer wait for our residents in the county to get the better outcome. You want us to make changes to improve services. This is a key step in that journey. We've made the decision now. The clinicians support that decision. It'd be great to be able to implement them and improve the services for the citizens we serve.
Thank you. I think it's helpful for that clarity for committee members as they make a decision moving forwards. It is a very finely balanced decision which way we go, I think, with this. And I've got Councillor Wootton who'd like to come in first of all, please.
Yes, thank you, Mr. Chairman. The campaign in Grantham is going on since 2004, so that's 18 years ago it started. So another year or so, which because the UTC, if it came to Grantham, wouldn't be here for another 18 months anyway. So I don't think a few more months to refer to Secretary of State will really matter. And I think we'll really improve and give a really clear decision to the public of the direction the future of Grantham Hospital will go in. So I think it'd be good to refer it. I have a question for Mr. Burnett. Mr. Chairman, he mentioned that a standard UTC, that Grantham would have middle grade doctors and a consultant. Is Grantham going to be a standard UTC or a UTC plus, as referred to many months ago in our committee? Because that would then imply it would be better services than a standard UTC plus. Thank you.
Yeah, happy to come in on that. So 2 things. I think the referral is years. They can take, as you know, it can take a long time to come out. So that overnight care, and sorry, apologies, forget the council name of that paediatric transfer. That's 2 years of that. There could be 2-3 years of that taking place. So I think the timescale is critical, and that support overnight. Obviously, the temporary change keeps it shut. So in terms of the UTC plus, so when we went as part of the kind of modelling and the discussions around the proposal prior to the consultation, the Lincolnshire NHS said it wanted it to be called a UTC plus because the model is far greater than you get in most UTC. I can't say every UTC up and down the country, but certainly your standard UTC model that I'm aware of in that sense. East Midlands Clinical Senate, in terms of their role was to scrutinise proposals of change proposals, clinical change proposals up and down the East Midlands, and have that kind of objective viewpoint on what that means, and did they support them or not. Said you shouldn't have plus. Because that is it's not a terminology that anyone recognises, and therefore will confuse what it is. What's a UTC plus against a UTC? So that's why that comms message is crucial. That's the reason plus was taken out. But this is a far stronger UTC clinical model far enhanced than you get in the other UTCs in the county. So you have no other, the other UTCs are GP and nurse led. This will have GPs, it'll have nurses, it'll have mid-grade A&E doctors involved who will have 40 hours of consultant oversight a week for their kind of role and for their clinical expertise. No other UTC I understand has mid-grade A&E doctors. I'm not aware of any, not just in Lincolnshire, any at all. It also, no other UTC has an ability to say, right, this patient needs a bed and admit patients into the hospital. There'd be the 70-bedded acute medical community bed provision behind it, and actually that will enhance support for kind of frail and elderly patients, because that community element is all around that, and because they will link with the community service out in the community in Grantham, will help them kind of return home. So I can't be any more stronger that this is not the UTCs you get in other anywhere else. That kind of level of provision, what will increase over the A&E, the GP element to it will increase the paediatric level of skill in the department, because A&Es generally wouldn't have that. The A&E doctors wouldn't have the kind of level of expertise the GP puts into it. But a UTC doesn't have those mid grades and that kind of support that goes alongside it. It has all the kind of X-ray imaging facilities that isn't found elsewhere. It has the 70 beds that it can admit patients into that have consultant and community support involved in terms of their care and assessing their care. So yes, so the UTC plus isn't a terminology that will be used, but and that's why that comms piece is critical. But as a centre, the proposal here will put in, it's not that dissimilar to the A&E. The key here is the terminology of A&E changed at UTC, because that is both clinical senates, the East Midlands and East of England, and the independent reconfiguration panel last time was quite categorical that name terminology should be changed, because that's not what the service is. It's not an A&E. So that's what's changing. And the fact that only 3% of patients will be transported, which is 2 a day, shows that actually the level of service provision that will be put in place 24/7 hours a day isn't too dissimilar to what it has, and is far enhanced on any other UTC I'm aware of. So I can really put that forward as a strong case, and I'm sure, I know you all know the local GP Dave Baker. He would I've had so many discussions with him, as Tom. He would fully back that up, and did back that up once the decision was made, because as a local GP he thinks it's a great decision to be made. It'd be really good for the local population, and I think that's someone's voice you should listen to, probably best than mine.
Did you want to come back at all, Ray?
No, Chairman, I think that's very helpful. We obviously now know that it's not a standard UTC, and it will provide more care. In fact, as much care as we've got at A&E at the moment, so I'm pleased with that. Thank you.
Thank you, Councillor Smith, and then I've got Councillor Parker, but I do want to be wrapping this up now. We've already gone well over time. However, it's such an important item, I think we do need that time to go over it.
Thank you, Chairman. I will be brief. These are just points of information which I think will help the committee in its wider work, and because of the points that have been raised today. In terms of EMAS, as far as I'm aware, and they can correct me any time if I am wrong, but I was certainly told when I was a district councillor a couple of years ago, from as soon as they became EMAS, they have never hit all of their KPIs. In fact, I don't think they've hit any of their KPIs. So that tells you the scale of the problem that we're going to face in Lincolnshire. In terms of GP working with what Dr. Wookey said, I'll use my personal experience. I was referred in that manner, but it did take them 6 months with my stomach being in agony because they kept saying, oh, it's this problem, and I kept turning around to them and going, no, it isn't. I know my own body. It isn't this. And, oh, no, it's fine. So they do it, but after a lot of argument, and you've got to have a strong will as a patient to go, I might not be medically trained, but I can tell you what it isn't. In terms of the A&E front door, again, that Dr. Wookey raised, that's certainly my experience when I've gone with somebody else, that it's a couple of questions and then sit down, you'll get seen whenever whenever the case may be, personally. So I don't think that that process, and there was a lot of, as has been alluded to, there was a lot of money spent on that. I haven't seen in my experience that works. There may be other areas in other hospitals, even in Lincolnshire where it has worked, but certainly when I went to Lincoln County with somebody, no, it didn't, Chairman, but I thought they were relevant points to bring to the committee's attention.
Thank you, Councillor Smith. Councillor Parkin.
Thank you, Chairman. I've got every respect for the campaigners in Grantham and every respect for Ray and Linda, and I congratulate them on the work that they've done, because campaigns like that always change outcomes for the better. And I also know that they're emotionally exhausting and incredibly time-consuming. I am really worried, though, about what we have been told about the implications for referrals to Secretary of State. And as much as I do take my hat off and I respect what has happened in Grantham, I think it's a fine example of what happens when the community can be mobilised. I would request that we have the most due diligence and take really, really seriously the warnings that we've just been given about holding this process up. Because what it would mean is that, not that these processes would be delayed. If we're looking at 2 years, we will be starting the clock again, because things will have moved on, things will have been changed, and we will then be looking at a totally new set of service reconfiguration that is needed, and we will be falling further and further behind in terms of where Lincolnshire needs to be. So with the greatest of respect, and I do genuinely mean that, I would just urge real caution in terms of how we exercise our community roles at this point.
Yeah, thank you, Councillor Parkin. I think I would fully agree. It is, as I say, very finely balanced which way we go. At the moment in time, we have obviously a recommendation from Councillor Wootton that we go for referral. I don't know if we have a seconder for that as of yet. What my suggestion is, if we don't get a seconder, I would like to say that what we would do is keep continuing to bring this back to the committee and ensure that we look at every element of the implementation to ensure that it is being done in the correct manner. However, it is the committee's decision in which way they wish to go with this. And I think, you know, that is what I would say going forwards. First of all, do I have a seconder for Councillor Wootton's motion?
Sorry, Chairman.
Councillor Cleaver.
Could we have more clarification on what our options are, please? Sorry.
Yes, certainly. We have the option to refer items that are part of the acute services review. We could do, say, stroke alone, or we could do stroke and we could do Grantham's A&E. We could not refer it at all and just continue to ensure that we have it brought back to us and we ensure very careful implementation is done instead. But those options are what's on the table for this committee to make the decision upon, and I would like a steer upon that. At the moment in time, I don't have a seconder for referral, so I would, as I say, probably move forwards and suggest that this is the best way forward to record the committee's disappointment with the CCG board's decision on orthopaedics, urgent and urgency care. Yes, I'll bring Councillor Parkin in a moment, and emergency care and stroke services, as these reconfigurations have not been supported by the committee in its response to the consultation exercise, to seek further reports on the implementation arrangements for the 4 NHS services, with particular emphasis on the arrangements for staffing, including recruitment and retention, transport and travel arrangements, including any new local discretions allowed as part of the national non-emergency patient transport arrangements, the extent to which the £1 million contingency plan allowed to cover the additional demands for the EMAS service and non-emergency patient arrangements is required. And also, in relation to stroke services, any details on securing the capital investment of £7.5 million to increase capacity at the Lincoln County Hospital, any details on how increased stroke patient numbers are managed by Peterborough City Hospital and Queen Elizabeth's Hospital Kings Lynn, and in relation to the Grantham Urgent Treatment Centre, confirmation of the service due to be provided at the Urgent Treatment Centre. So that's the other option on the table. I've got Councillor Parkin first.
Sorry, Chairman, I'm jumping in. I was just saying that I would second that when we get to it.
Okay, thank you. Councillor White.
Sorry. I would just say that I think the evidence is so strong that if it were referred to the Secretary of State, you would not be successful because they've got so much information and evidence.
Thank you, Councillor White. In which case, we haven't got any other proposals that have been seconded. Councillor Cleaver.
I'm sorry, I will second Councillor Wootton. If I understood it correctly, I will second his proposal to refer the Grantham urgent treatment emergency decision on the basis that it is based on incorrect population projections.
Okay, thank you. Within your recommendation going forwards and motion, did you want to include any other elements of the ASR?
My only concerns which I spoke to this morning was the stroke, proposals for stroke. I think at the moment they're flawed. Thank you, Chairman.
Yeah, we would have to do them separately, but would you be happy to second that as well? No. Okay. So again, without a seconder, stroke wouldn't move forwards, I'm afraid. Okay, we've got two options on the table. I believe that it will be Councillor Wotton's motion that will be first to be voted upon. I think we'll see how that turns out, and then it falls back to my proposal. So we've got that proposal on the table. All in favour of referral of Grantham A&E, please show. That's 2. Those against? So that motion has failed. In which case we go back to my motion, which was seconded as well. All those in favour, please show. Okay, I think that was carried unanimously. Thank you. Okay, well, thank you all very much, and thank you to our presenters. We'll now move on to the next agenda item. We'll now move on to agenda item 8, the second Community Diagnostic Centre for Lincolnshire. The item was circulated as part of the agenda pack from pages 329 to 348, and I would like to welcome our very patiently waiting presenters, Sarah Brinkworth, System Planned Care Programme Lead for the NHS Lincolnshire Clinical Commissioning Group, and Claire Raybould, Director of Operations for NHS Lincolnshire Clinical Commissioning Group. I'll hand over to you just for a brief run through, and we'll take questions at the end. Thank you.
Thanks, Chairman. I think on virtually we've also got Claire Lloyd, who is our project lead for the Community Diagnostic Centre.
Okay, and welcome to you as well, and thank you.
Yes, if you don't mind, it would be helpful to kind of go through them. So we've been asked to attend today as part of our engagement that we're doing around our second Community Diagnostic Centre. As the Chairman's introduced me, I'm the System Planned Care Lead, and we've got the Senior Responsible Officer for the programme in Claire Raybould sat here, and as I've just introduced, Claire Lloyd on the phone. So we'd like your feedback on the proposals that we'll talk about today, but I also thought it'd be helpful to give some background and some context into where we've got to with the community diagnostic centres, because I appreciate it hasn't been to this committee before. I'm also aware that we've probably got members of the public watching, so if they'd like to give any feedback, our survey, patient survey is still open, and I'll ask for it to be shared on our social media channels again this afternoon, but you can find it on our website. If you'd just like to move to the next slide, please. So I know you've already had the slides, and I'm sure you've got a few questions, but I'll go through them and explain in a little bit more detail, and we'll take the questions at the end. As a general overview, the CDC programme is about increasing capacity for diagnostics. So we aren't looking to change any of the existing patient flows to the existing providers, and patients will be able to choose where appointment is most suitable for them. Next slide, please. Thank you. So just a bit of background. The CDC programme came about following an independent review by Sir Professor Mike Richards, which was published in October 20, and the link's as part of the slides. The review set out the need for radical reform and investment in diagnostic services. Its main theme was to increase diagnostic capacity and for a new model of diagnostic service provision. Along with the recommendation to separate acute and elective diagnostics, was also the recommend to expand the diagnostic workforce and improve connectivity across all aspects of diagnostics, as well, of course, the development of community diagnostic centres. The intent of CDCs is to provide a broad range of elective diagnostic services away from our acute facilities. This programme is planned to be rolled out over the next 5 years, of which we're currently in the second year. Next slide, please. Thank you. So I won't read out all of those primary aims, but also to say that the programme's been asked to consider several other aims as well. So to improve staff satisfaction and development, this is by offering new roles and development opportunities. To deliver health promotion and or signpost other services where it's meaningful to do so. To contribute to the NHS net zero ambitions by enabling fewer outpatient attendances and reducing patient journeys to the hospital sites. And to act as anchor institutions, consciously supporting positive social, economic and environmental impacts locally through the workforce and training and wider local regeneration. Next slide, please. So the four bullet points on the slide have been taken straight from the national CDC specification. And when we submit our business cases to NHSCI, we have to demonstrate that the CDC will meet these. We also have to demonstrate that by the end of the programme, CDCs will be able to book patients in for a coordinated set of tests on the same day. The CDCs must have the digital infrastructure and connectivity to share data and outcomes across the system. And they must carry out a minimum range of tests, which is included on a later slide. Next one, please. So, other considerations that we've got to go through. Again, I won't read all of these because I know that you've seen them before, but just to add that our plans should consider the costs of converting any buildings and the flexibility of our existing estate to meet the changing diagnostic needs and to be able to future-proof our sites. We also need to look at what developments are already ongoing and whether we can integrate into these programmes of work. And particularly, I just wanted to pick up the bullet point on speed of deployment. The committee may know that we've already started a CDC in Grantham, and we had to mobilise that quickly during last year due to the funding bid timescales, which is what it's referenced there. Next slide. Thank you. So these are the minimum required tests that are expected to be as part of a CDC once it's been set up. There's acknowledgement that not all of these will be done at the beginning and that they'll be mobilised over the duration of the programme. These tests have been agreed as a minimum requirements by the National Clinical Advisory Group, CDCs, but there is an opportunity for systems to include additional tests if it's appropriate for the population needs. Next slide. The national guidance explains that there's no limit to our design to the archetypes that are listed as part of the specification and that are put up here. A blend can be considered as long as the minimum requirements are met. So we're encouraged not to constrain our thoughts around just these particular models. Even just last week, we had some clarifying guidance on what a spoke could be, that it could be a smaller CDC and doesn't need to include all of the minimum tests that the main site would have to. But it has to be in a fixed location that has a postcode and be given a named designation. It can also be for a specific number of days rather than 7 days per week if the demand isn't there. Next slide. Part of the CDC's programme is also to consider what pathways need to be going into them. So these pathways are the ones that have been nationally suggested that would work well in a CDC. The first pathways that are under development from a national perspective are the cancer and the breathlessness pathways. And once they've been developed, we will look to adopt them. Locally, we've already engaged with our heart failure team, as we know this is a priority for the Lincolnshire system. We're also working closely with our colleagues in public health to understand what other areas may be a priority for our population. The aim is to have all of the required diagnostics for those agreed pathways in one location so that the patient will only have to attend once to get the necessary tests completed. Next slide. This slide briefly explains the journey that we've been on in the last 12 months. So last May, we established the programme, which is jointly led between ULHT and the CCG. This has proved really successful in being able to mobilise the resources required for a project of this size. As I mentioned earlier, the timescales to access national funding were extremely tight last year. We recognised the importance of this programme for Lincolnshire and didn't want to miss the opportunity to start something as quickly as possible. We'd already invested in some provision away from the main hospital site in Grantham during the pandemic, and so we thought that using this site would enable us to mobilise additional capacity quickly and to support with the COVID recovery. Our focus for last year was to bid for funding to support the diagnostics that were struggling to recover from the pandemic. So these were X-ray, ultrasound and echoes. We quickly identified that workforce, as we've already talked about today, was going to be our limiting factor, and we've engaged with Lincoln University around starting a radiographer course. Lincoln Uni remain part of our CDC working group, and it's hoped that the course will start from September 2024. As soon as the funding was approved, we started to increase capacity to support the COVID recovery. We didn't want to wait for the building works to be completed at the Grantham site, so from November we did additional clinics at weekends in order to see as many patients as we could. The funding that we accessed last year was for 1 year only, and so we had to submit bids to be included in the National Spending Review in October 21. This included what we thought we might need to deliver 4 CDCs within the county. Guidance from the national team suggested that systems needed to plan for 3 CDCs per 1 million population, but we'd been advised to add an additional one due to our geography. Unfortunately, we didn't get all of the funding that we'd asked for, and so we're adapting our plans and thinking of alternative solutions. And as you can see up there, we started our initial engagement at the beginning of 2022, which there's more detail on later in the presentation. Next slide, please. So that's what we have been doing, and this is just trying to explain what our focus is at the moment. So the expansion of the site at Grantham to include plans to implement all of the minimum tests over the next 3 years. Development of the second CDC business case, which is what we want to talk to you about today. Estate sites are being scoped in conjunction with the district councils and the NHS estates teams. We're continuing to work with public health. The work that they've done helped to develop the short list of potential sites for the second CDC, which balance the catchment area with access inequalities. And as I mentioned earlier, we want to start developing the pathways that will benefit the Lincolnshire population. We've also been in touch with service areas at ULHT to understand their requirements in gaps in service provision across the county. We'll also continue to liaise with NHSEI regional team around our business case development and any available funding for the programme. Next slide. As I mentioned earlier, we started our initial engagement at the beginning of this year, and our dialogue has happened early in our process. We're holding extensive discussions with a wide range of people to develop a robust business case, and we want views from all of our patients where they would like to participate. Next slide. This slide just shows the engagement process that we've been taking, and we're at step 3 on the right-hand side in the green box at the moment. Next slide. From our first phase of engagement, we heard that future CDCs should be placed in areas that are easy to access and close to public transport links. They should have ample parking on site that's either low cost or free. Should allow quicker access to appointments with rapid diagnostics and shorter waits for treatment. Deliver services locally in the community for local people. Offer a choice of location of appointment. Offer extending opening hours. The concerns from the first phase of engagement that we should try to mitigate are transport from rural communities, fragmented services. There was a concern that services would not be joined up or that there would be a lack of communication between specialties. And our ability to staff the new units with the known workforce challenges in the county. Next slide. So the phase 2 engagement is underway and prompted us to be here with you today. From the stakeholders that we've engaged with, we've received feedback from all of our neighbouring borders, so North Links, Nottinghamshire, Cambridgeshire and Peterborough, Norfolk and King's Lynn Hospital. To date, we've received over 2,000 responses to the public survey, and it still has a couple of weeks to go. Mentioned earlier that it's great that we're able to have feedback and comments from so many areas, and I would encourage anyone that still wants to give their views to please do so. We're also conducting a patient experience survey, and we're asking for patient volunteers who want to play a more active role in shaping the future of our diagnostic services, either by attending workshops, focus groups, or one-to-one interviews to discuss our plans and pathways in more detail. The options we're considering on the location for the second CDC are the ones on this slide. These have been developed following the phase 1 public engagement, the identification of health inequalities, considerations of demand and capacity gaps, and the available funding and workforce. We've also taken into consideration the national guidance around what a CDC must be able to offer. All the public and stakeholder feedback, as well as financial options appraisal, will be presented to the next CDC project board in July for a decision to be taken on the location for us to submit the next business case. That's one. So as I've explained, our next steps are to expand the Grantham CDC to include the full range of tests, develop a second CDC in the county, which the East Coast does remain a key focus for us. And for future CDC opportunities, we'll be working with the developing PCNs and any additional capital projects where we might be able to include CDC services. We know with a county as large as Lincolnshire, CDCs will provide valuable services for patients without them having to attend a main hospital site and support our non-emergent elective pathways by freeing up capacity at the main hospitals for emergency patients. That's it. So unless either Claire or Claire Lloyd on the phone have got anything to add.
No, I think... No, Sarah, you've got...
No, that's fine, thank you.
Very well.
Thank you, in which case we'll open up to questions. I've got Councillor Allen first, please.
Thank you, Chairman. Although my question stroke comment might have been frustrated by your last comment that you're going to seek a decision in July, was it, in terms of location? Because what I was going to say was that I find it quite difficult, and I've read through the report twice, to actually pick one of these out of the options as we got put forward to us on a technical basis, and that's nothing to do with the report itself. I think it's to do because you know it's obviously work in progress to a great extent, because there are a number of options within what a CDC is and what it will actually provide. It's obviously difficult, I think, to almost cherry pick across the county in terms of picking one here and then where's the next one, as opposed to having a plan that says if we did it this way, we would get a good match of sizes of CDCs and locations of CDCs and coverage of the population. And I accept that that might not be a practical way of going about it because of the limitations that you might have in terms of what is available to you and what finance might be available to you. So I find it quite difficult, I must say, to actually pick one of these out on a technical ground, apart from saying, you know, well, should more go to Lincoln? Probably not. So there's left two options, and I'm not totally sure then, you know, where you would actually go. They're both, to a certain extent, serve the eastish side of the county, and the difficulty of moving to Skegness or Mablethorpe or those where there is an equality demand probably, is that if you put a circle around that, half of it's in the North Sea. So it doesn't necessarily perhaps give you the coverage that you actually want in terms of providing benefit to the you know, the people of Lincolnshire. So I would probably go for Louth, but you know, that is up to the chairman then to actually try and work out how we do pick one.
Thank you, Councillor Allen. Yeah, that'll be fun at the end. Councillor Harrison next.
Thank you, Chairman. Obviously, recommending and supporting East Lindsey. I'm obviously very much support the idea for Louth with the spoke. And I'm surprised that one of the things mentioned in the paper is that use at Louth is difficult because patients are unwilling to travel, which I find that really very, very surprising, because I was up at their car park only the other day and it's really almost always full to capacity. And obviously, if the day case orthopaedic is going to move to Louth, I would have thought there would have to be improvements to car parking facilities in any case, which added to a CDC would possibly deal with a lot of the problems in that direction. But I find it really surprising that people are finding it difficult to go there. It's got a UTC in it as well, so local people are used to going to that as well. Thanks, Chairman.
Yeah, thank you, Councillor Harrison. Sadly, that is the case. So, and particularly it's around the diagnostics that we have available at Louth. So it's not about the other services on the site. You're quite right. It's a busy, well-used hospital. But the diagnostic services that we currently have on that site, we really struggle to fill clinics. And that means we're sending clinicians over there to run clinics where they've not got a full list of patients. So, you know, when we were looking at the options, clearly the East Coast, from a health inequalities, and we look at where the need is, that would identify that's the next place where we would need to be looking. And picking up your point about where you might look if you were looking right across the county, I think the difficulty we've got at the moment is we don't have a funding stream that sees us open 5 or 6 of these. We are at point 2, so that's the challenge. So that's one of our reservations about Louth. We already know that that's an issue. So if we add more diagnostics into there, will patients go? So that's the rationale. I don't know if you want to add anything, Sarah.
Thank you. Okay, Councillor Parkin.
I'd like to thank Councillor Allen for being my warm-up act. Obviously very much concur with what Councillor Allen and also what Councillor Harrison has said. I think I'd like to flip what you've said on its head, really, in that if Louth just becomes the centre, could it in fact help answer the other problems that you're finding in terms of, you know, the people's willingness to go, if it has that kind of people's perception of it improves as a hospital, could that in fact counter some of the other difficulties and challenges that you're facing? I think one of the advantages of Life is clearly the MRI scanner that we already have, and the huge amount of public support that I know is already generated in Louth for this idea. I've seen loads of stuff on social media, and I can wholeheartedly say that this would be very, very much welcomed, not just from the medical community in Louth, but from the residents of Louth as well. And I think I agree with Councillor Allen that we are, in terms of acute care, I reluctantly accept that we are where we are in terms of centralisation. But and I don't like it, but we are. It's, you know, the reality of it. But I really, really hope that in a rural county like Lincolnshire, we can resist at all costs the urge to do that with all of our medical services, and that we really recognise. I mean, obviously, I'm incredibly parochial about Louth, and I will carry on doing so because that's what I'm here to do. That we carry on recognising not just Louth, but all of our community health facilities as being absolutely crucial. And I think the most encouraging thing, Sarah, that you said today was the bit where you recognised the knock-on impacts, not just medically, but to the whole communities of having a centre such as this, because they have social impact, they have economic impact, and that to me is really powerful that you are including that in the assessment. But come to that anyway.
So part of our conversation with Northlinks CCG they've indicated that they're looking to put a CDC at Grimsby and Scunthorpe. So part of our thinking was around, actually, if we put one at Louth, there's 3 quite close together. And with the funding streams that we've got, is it better to focus somewhere else to start with? And whatever decision we make won't exclude other things happening as well. So I think during the slides we've mentioned that for a CDC to be called a CDC, it has to have a specific number of tests. That doesn't mean that we won't do other things at Louth. It just might be that we won't do everything at Louth that wouldn't allow it to be called a CDC.
Thank you. Anything further? No, thank you. Councillor Chalmers.
Thank you. I love this, and I used to live overseas, and there was CDC centres, and they just worked perfectly. My thoughts on location would just be Skeg and Mablethorpe have got poor transport links. In case of an accident on the main routes in, that could actually have an impact on your day, basically. I like the fact that it would actually clear spaces within hospitals. Hospitals would just be hospitals for treating sick people in the moment. But also the car parking. Councillor Smith commented on the fact how hard it is just to go for an appointment at the in the last section. So clearing spaces by having diagnostics elsewhere just works perfectly, and it's a less stressful environment for people in a world where mental health is massively important. So I really liked both Louth as a location and Spalding. You had Spalding on the list. So there, thank you.
Dr. Wookie next, please.
Thank you, Chairman. We'd had a brief discussion about this last month, and I think there seems to be general acceptance on the general principle and the desirability of having diagnostic centres as is proposed. But the big question that nobody really wants to answer is the staffing. How are they going to be staffed when we already know that the people who are involved in diagnostics, whether it be pathology, X-ray, etc., are all rare birds, very difficult to recruit. And are you actually going to rob Peter to pay Paul and take people out of the existing diagnostic centres in the hospital and put them on a different location? Yes, that would save transport, particularly on the East Coast, but I can't see the logic of moving people across Lincoln and then setting up another diagnostic centre and the staff shuffling between the two. And to a lesser extent, that applies in Boston as well. So I think that really has to be answered as to how you are going to staff these centres. It may be that the answer is a gradual move in towards over a period of time to fully staff them. Because it's going to take, if you're going to talk about training people at a university or a college, that doesn't happen overnight either. And so it's going to be some years before those people start to feed in. And they're also strictly in demand for all sorts of other things in the NHS. We did touch last month, and I got a sort of half reassurance that there would be open access to these centres from both, obviously, hospital departments, but from primary care as well, and maybe what we've read in the last few days, pharmacies as well. And therefore, that needs to be cleared up as to whether they are actually open access or they're not. If they're not, then basically they're a waste of time, because you might as well stay within the hospital if it's a hospital-ordered arrangement. So I think there are questions to answer, although the principle is very good. I won't comment on the location at the moment, except that there doesn't seem to be much logic in having it right by a main centre. So those questions really would be very useful to have an answer to. Thanks.
So I think it's fair to say I don't have a total answer for the workforce challenge. I think nationally it's a risk. We've talked about it all day today. It's not just a new thing either. But we can't not try because of that. I think we've got a really good opportunity to deliver extra services within Lincolnshire. We're getting additional funding in from national government for it that's going to bolster our services for our population. So the kind of things that we've talked around the workforce risk is that these are new models of care, and the model that we're talking about at the moment is mainly with ULHT. So we're not looking at taking staff out of ULHT to put those services at risk. It's about offering opportunities to work across both the acute sites and a community site, so that it gives them something different in their working role. We're also looking at different models of specialists. So whereas we've got the traditional radiographer doing this service, actually in future we might be able to have other clinicians doing different tests. So we're trying to challenge our current services to think of different ways of doing it. And then, like you said, we are starting conversations with Lincoln University. We want them as a key partner in being able to grow our own, similar to what Pete said in the previous presentation. So we're trying to mitigate the risks as much as we can, but recognising that every system is saying the same thing through to their region and through to the national teams on the CDC programme. Do you want to say anything else?
Yeah, just the only thing I would add, I mean, it is a significant issue for us, and what we won't do is put something in that destabilises another service. That's not what it's not our job, is it, at the end of the day? So it's to recognise it's a fair point to raise. Just a couple of other points. So around the Lincoln-Boston location on here, just to be really clear to committee, that isn't on the hospital site. So I don't want people to be going thinking that is a Lincoln hospital location or a Boston hospital location. CDCs can't be on acute hospital sites, so hopefully that reassures the committee. And I think Sarah's point earlier about the minimum requirements for CDCs. So in order for something to be called a CDC, there are minimum requirements. That doesn't stop us improving our diagnostic capacity anywhere across the county. It's something we're working with primary care networks on, even just for taking bloods, for example. So there are lots of other opportunities that we're scoping that will come under the banner of the programme, but wouldn't necessarily be called a CDC. So just to, again, give you reassurance, this isn't just a fixed piece of work that we're doing, it is much wider.
Okay, thank you. Dr. Walker, you'd like to come back?
I've turned it on instead of off. One question hasn't been answered, and that's open access, which is actually crucial to the whole thing.
So in terms of that, GP, at the moment, the model of care is the same as what you would be referred into the hospital for. So as a GP, you would refer a patient for an MRI scan, goes into ULHT, if that's where the patient chooses. They could either choose to be seen at Lincoln or at the Grantham CDC. In future, as I mentioned on one of the slides, one of the options is to consider self-referrals. It's not a mandatory thing for CDCs, but we want to be able to receive referrals from all areas of the NHS, and patients can then choose the location that's suitable for them. Is that okay?
You'll need about double the staff if you're having self-referrals.
Okay, thank you. I've got 4 more speakers and I'm going to close down the debate. So it's Councillor Smith next, please.
Thank you, Chairman. Going on back to what Dr. Walker just mentioned, you may need double the staff, but I think self-referrals are actually quite important for CDCs to become something more than just an extension of or removing pressure from an A&E. They will actually become something far greater and something far more important in the health system if you allow self-referrals, but obviously with proper guidance around when it's appropriate to self-refer, so you don't get everybody actually self-referring when they actually don't need to, so because that's wasted resource. Much like Councillor Parker, I'm going to be a bit parochial here on my patch. I'd hate to see Grimsby's CDC diluted, because that's where most of my residents will actually go because of how spread out my division is. How would that work? Because obviously that's, correct me if I'm wrong, I believe that's a separate health authority. So how would that work in terms of appointments? Would it be, well, you're outside of the health authority, so your appointment's going to go further down the list, or is it simply on a clinical basis of your clinical needs here, yours is there, so you'll go there because that's where your clinical need is, and that's where you've elected to go, much like you can elect to go to, say, Nottingham for other treatment. Thank you. I can see by the nodding you clarifying that, yes, that is how it works, which is good to know. But I'd very much like to see how it's, as Councillor Ann said, how it's assessed that the locations determine in terms of Lincolnshire. And it'd be actually very nice, Chairman, if we were able to have a discussion with our partners across the border, sorry, I should say, in Humberside, as we did with their acute programmes around the Diana Princess of Wales Hospital and other parts, because for my residents especially, that will have a major impact on them, because that's where, as I say, most will actually go, or they'll go to Peterborough or over the border, as it were. But no, it's a very good paper, and I think these should be welcome. But I think we, as much as we can, should be looking to try and get them to be something more than just a pressure valve release from our main acute hospital sites, and try and get support as much as we can the move to self-referral. But as Dr. Wilkie said, you will need the staff to do that. So I think that's an issue of funding and trying to be as supportive as we can in that sphere. Thank you.
I think in terms of the self-referral, I think we need to take this slowly based on the comments that we've had earlier around workforce, don't we? So you'll have heard on the news today about pharmacists being able to refer for tests. So I think there's something about expanding it to the health professional of the groups first so that it can be contained. Then when we know we've got other courses on with the university and we've been able to grow different types of workforce, we could then start to think about self-referral. I would doubt anywhere will open self-referral up, and my brother works in Australia, so very similar to your experience, and that's how they started these out there. But now you can go to your local shopping centre and they've got one of these diagnostic centres, and I think that's the vision, but we've got to build to get to there without tripping ourselves up on the way, I think.
Thank you. I've got Councillor Rice-Oxley now.
Thank you, Chairman. Yeah, the Grantham CDC is in my district ward on Gunnerby Road, just north of town centre, which is fantastic. And I recognise the crucial role it's already playing in the delivery of diagnostic services and improving outcomes for patients. It's great. I very much welcome the expansion that you've spoken about. We do have a growing population in Grantham, so that's terrific. It's great to be discussing a second site. Hopefully funding will emerge for more, though I acknowledge Dr. Wilkie's comments. Could you clarify with this decision about the location, is this likely to be the second and last for Lincolnshire, at least for a while? Or, you mentioned the one in Grimsby. Could there be a third? So in choosing a site, are we looking at the greatest need right now? Or is it a building block in a wider CDC strategy? Thank you.
So in coming to our preferred option for a second site, it is part of a long-term plan, but recognising we don't know when that funding will come. So we need to make the best decision for now, which is why I reference the health inequalities that we have on the east of the county. We've made a collective view on that, haven't we, as a health and care system across Lincolnshire, that is significant. And if we look at, we've looked at, and I know you don't see that here because it's part of the detailed work that we've already done, when you look at some of the outcomes for some of those patients and the pathways that they are accessing and their levels of deprivation and all of that, that you come to a conclusion naturally that the east of the county would really be where you would want to site your next one. That doesn't mean that you wouldn't put any others in the county. I think what we can't say today is we've got funding for a third, fourth, fifth, but you'll have heard this from government, this is a national priority. I don't see this going away. I think we will have more. I just don't think we can say to you now at what point they will be. But the evidence that we gather through this engagement exercise will inform business case for CDC2. We will also use that evidence to form the further business cases and do further engagement. So hopefully that answers your question.
Thank you. I've got Councillor White next, please.
Thank you. Given that for various reasons there's often a long delay in referrals from GPs, how will you achieve your aim of reducing unwarranted variation in referrals?
Thank you for your question. So I think often the delay is not in the referral, it's in being able to be seen once the referral is made. So once the GP makes the referral, that goes straight into the system. It's about the availability to see them, isn't it? Hopefully that's what you're referring to. So we do have variation at the moment. If we look at our GP practices and we look at data across our county. So some people use different pathways in different ways. We've heard that today already. Some GPs will ring up a consultant and get advice. Some will just do a referral. Everyone does it differently. So the unwarranted variation is for us to try and tease that out and make sure that all of our clinicians, whether it's GPs, whether it's nurse practitioners or the pharmacies, as they come on board, are using the right pathways so that we can stop having people going into the wrong services. We know already that a lot of diagnostics are undertaken as people are referred to, let's just say they're referred to, I don't know, trying to think of a specialty, but say they're referred to any specialty in the hospital, but actually what they really needed was a diagnostic test and that would have answered what their need was before they needed the referral. So if they sit in that long wait that you're just talking about, where actually the test could have informed what they did next. So it's about making sure we use the data around variation to take that out, really. That's what we're talking about.
So therefore, it's very important all members of the public are aware of this option, so that when they go to the doctor, they can say they'd like it if they would like it.
Yeah, absolutely, and that hopefully the engagement that we're doing now is kind of putting that message out there with the public about this is an option, and then yes, you're quite right. It's about that choice stage when patients are referred. They could still choose to go to a hospital, but they could go to these sites as well.
Councillor Cleaver.
Thank you. Sorry, I apologise for missing the beginning of the presentation, so forgive me if I'm asking questions that I would have heard if I was present. I get the impression we're being asked the wrong question in a way here. I would much prefer to see a plan as to how you're going to cover the whole county between standards, large and hub and spoke first, and then have a discussion about the priority in which they're implemented. At the moment, I'm not seeing what your entire plan is for the whole county, and then which one's going to go next. What I'm seeing is we're asking to make a decision on number 2 without knowing what the total number is going to be in the end and where they're going to cover. And obviously particularly anxious that I've not seen Bourne, Stamford and the Deepings mentioned anywhere as well. I think most other places are mentioned in the list there somewhere or other, which begs the question, which is a constant concern for us, has the Leicester, Leicestershire and Rutland CCG been contacted in terms of having any cooperation in terms of a hub and spoke across the border into Rutland, which is quite a long border between South Kesteven to the west of South Kesteven. The other thing which I think I'm getting a reputation for asking is about IT and connectivity. I noticed that one of the conditions is that it should be fully digital. Does that mean if I go to a CDC and have some tests, I'll see the results on my NHS app fairly quickly afterwards? And I take it for granted, but please confirm that any referring body, be it a hospital, be it a GP, be it primary care network, will access everything online in terms of asking for the referral to be done, for the referral being done online and seeing the tests all done online. In other words, the whole thing is completely paperless from day one. Thank you.
Thank you for your question. Am I on? Yes, sorry. So in terms of have we got a plan? No, there isn't a plan at the moment. So I'm just being really frank with you. This is a national programme. It came during COVID. We had to try and do the best we could. We were really fortunate that we had the green site at Grantham at the time because of the pandemic. Not fortunate for other reasons, but it was. And we had the Gonnaby Road site at Grantham that we were able to build into a CDC. If we hadn't have had that, just logistically, we wouldn't have got CDC 1 up and running. And then we had to put in a bid really quickly for, or thinking around CDC 2. So at the moment, what we're asking is for your views in terms of our engagement. It's not a decision, we've not made any decision. And all we will be doing is putting a business case in to get the funding for CDC 2. So we've got further down the road to go. But we know it's such a priority national programme that there will be slippage in other areas. We know that that's happening already where people have said they're going to build a new site and haven't been able to. We need to be ready that we can implement our CDC 2 as quickly as we can. So that's the process that we're undertaking. We have an eye to where we would have them in the future, but being really honest, you know, if we were looking at the whole county, we probably wouldn't have put the first one in Grantham, would we? We would have put it somewhere else based on the data that we've reviewed, but we didn't have that option. and it was already there, and actually it is seeing patients from across the county, and patients are really willing to travel, which has been quite interesting for us when we look at some of the other things that we've talked about today. Because it's speed of access, patients are willing to travel, and they are going to Grantham. So I think, you know, yes, we would have loved to have come to you with this is a 5-year plan, and we're going to do this one and this one. We haven't had that luxury of time, unfortunately. So we're coming to you with, this is the engagement that we're doing with the population to try and steer ourselves in the right direction. We will use that feedback as part of all of the other work that we've done around what are the health inequalities, what is the current access, what do people need in terms of tests, and where are they currently going for those, how are they getting there. We will pull all of that data into our decision making for our business case, but it is at that stage just a business case. And then we're very mindful that we need to think about where 3 and 4 is, and that is in our plan to do that. We just don't have that at the minute, and all of this information will help us inform that. So your point about Stamford and Market Deeping is also well made, and one of the difficulties with a national programme like this is every county is doing what we're doing, so every county is looking at where they're going to put theirs, so and everyone will be making their decisions at different points in time, so we won't necessarily all know that in the right way, but we are, Sarah and Claire, who's on the call today, are well engaged with our neighbouring counties, so Leicestershire, Nottinghamshire, Cambridge and Peterborough we just talked about, and North Lincolnshire, so that we can try and avoid a scenario where Nottinghamshire put one in Newark and we've got one in Grantham. That's you know, that's great for both of those populations, but for the total of the populations of both those counties, that wouldn't be a great first choice, would it? So we're trying to balance all of that, but it's not easy, if I'm honest. So we're trying to do the best we can. In terms of the digital, you're absolutely right. The ambition is that it's all digitalised from day one, and that we get to that, or we get to that point by the end of the programme. Actually, is the ambition. And yes, you know, all of us would want to be able to see that on the NHS app. That's not possible at the moment for probably because of a range of diagnostics. You can't see that, but you might see the report. What we're trying to do is get to that position where it's shareable, and at the moment for most tests it is, so those reports do come in quite easily, but we need to make sure, and that's why they've set that out as an ambition at the beginning, because a lot of new services start without thinking about the digital aspect, so they just start running and then they think, oh, how are we going to communicate this with everybody, and we start, you know, I won't say go back to faxes because we have moved past that thankfully, but that is an issue for us, so it's baked in at the beginning to make sure that we get that digitalisation right. I don't know, Sarah, if you want to add anything to what I've said.
So I'll just add a few things just on LLR. So like Claire mentioned, we have spoken to all of our neighbouring providers. I suppose the benefit with LLR and Nottingham is that they're in our own NHSEI region. So we have monthly steering groups with our Midlands NHSEI region where we talk about all of the plans for CDCs. I'm not aware whether theirs are in the public domain yet, which is why I kind of don't want to go into too much detail. But we've then had the conversations with the north and the south of our border because we know that they're in our different regions. Whereas the Midlands is very structured in terms of how we can talk to our neighbouring providers. And then just a bit on the digital connectivity, just to give some assurance. I mean, apart from workforce, that's going to be one of our massive areas of focus. And as part of the governance structure that we've got underneath the project, we've got a separate digital workforce so that we can make sure that it's connected into all of the other digital strategy work that's going on within the county. I didn't mention it too much in the presentation, but part of the future models of work is that there might be multiple different providers that are providing some of these services. So we know that we've got workforce constraints and we might need to look at maybe not just ULHT, we might need to look at independent sector providers supporting us with some of this. We need to make sure that whatever they're doing we can see, and similarly, so that we don't duplicate anything. So that's a big part of what we're trying to do.
Thank you.
Okay, thank you. I've got no other speakers. I've just got 2 questions myself. What is your preferred option out of those that are listed, and what is your reason for it?
I mean, we don't have a preferred option as an organisation because we haven't had that debate yet, and we genuinely do want the feedback to come through. Personally, I can tell you what mine is, and that's Boston with the spokes that are described in the paper. And that's just based on the evidence that I've seen of the population need, where they're currently going to, and particularly that Skegness and Mablethorpe bit is a real challenge for us. Those patients really struggle to get to services. So whilst I said earlier, patients are quite happy to travel from to Grantham, they are from most of the county, but if you live in Skegness, they're not. And so that's a personal view from me, so it doesn't represent the view of the organisation or of the project board. That's just a personal view from the data I've seen. What I do want to see, though, is what the public are telling us and what they think. So that engagement, I would stress that to all of you and to any of your discussions that you have with your constituents, that actually it is about what the public also want to add into that. That's really important to us.
I suppose just to add into that, the Boston option would also support our non-elective pathways. So whilst Claire mentioned it's not necessarily going to be at the hospital site, it will provide the capacity to help improve pathways through A&E by moving some of the outpatient and elective diagnostics away from the hospital. So there's capacity there to see patients through A&E in a quicker way. Also, if inpatients need diagnostics, we've got more capacity on the site there. And again, part of the longer term strategy for improving diagnostic services is by streaming the outpatient and elective diagnostics away from your acute sites. So I suppose just to support that option.
Thank you. I think we've got Claire as well online that wants to come in.
Yeah, good afternoon, everybody. I just wanted to join my colleagues by saying we are particularly conscious around the social deprivation around the East Coast and how we improve those outcomes. So the option around Boston and the spokes, so a hub in Boston and spokes out into the East Coast, is certainly an option that we feel would support both streaming our patients from elective and non-elective and tackling the health outcomes for those patients who find it difficult accessing healthcare at the moment.
Okay, thank you. Just got one more question, and that is, a hub and spoke model was proposed in 2 of the options. Can you give any more details on what would be planned in the spokes? For example, would they offer a limited range of tests or operate as a set number of days per week in a mobile unit?
So at the moment, those sorts of decisions haven't been made. I think it will depend on demand for one of it. So we don't want to put clinicians in a place where there isn't the demand. And we know that there's probably unmet demand out there that we need to manage as we go through the programme. So we're particularly looking at the pathways elements and what tests will be useful for those areas of the population. So those sorts of decisions are still to be decided. We've got quite a way to go with figuring out what would work there. We're prioritising where we know we've got capacity issues for now, and what will help those geographies to be able to access services quicker.
Okay, thank you. In which case, it's down to the committee then to decide which option they think is preferable to them. I think we've already had put forwards from Councillor Parkin and Harrison that they would like to see Louth. Personally, I think Boston would be the right one for myself, so I'm happy to go in whatever direction the committee would wish. So I'll throw it out to you there.
Could I propose Louth as our recommendation?
Okay, so it's been proposed and seconded. Councillor Allen, did you want to? Okay, go for it. Okay. It's, yeah, seconded, third and fourth, I think. So, okay. I think it's been seconded by Councillor Chalmers. Okay, in which case we'll go to the vote. All those in favour of, I think it's the Boston one first. So, all those in favour of the Boston site. Okay. All those in favour of the Louth site? Okay, I think the Boston site's won. Thank you. Thank you very much, and thank you very much for your presentation. In which case, we'll now move on to Agenda 8 and 9. Apologies for the long wait you've had to come and speak to us, but the item was circulated as part of the agenda from pages 349 to 393, and our presenters, if they're still there on Teams, are Rose Lynch, Senior Commissioning Manager, Jane Green, Commissioning Manager, Adam Morby, Regional Chief Dentist for the Midlands, Kenny Hume, Lincolnshire Local Dental Network Chair, Jasmine Murphy, Consultant in Dental Public Health, and we have Sandra Williamson, who is the NHS Lincolnshire CCG representative also, and Lucy Gavins, all in attendance. So I'm not sure who's leading this, but I'll hand it over to whoever it is now.
Thank you, Chair. It'll be myself first, if that's okay. I do have a presentation, but dialing in, I've noticed that only the presenters or the organisers can present. So I've just sent in the attachment to Simon, if you can present the presentation, if that's okay. Oh, is that so that I can present as a... Okay, let me share the screen. Thank you. Okay, can I just check that everyone can see that?
Yeah, we can see that, thank
make
you.
a start. Oops. Wait 1 second. One. I'll start again. There we go. Can we still see that?
Yes, we can, thank you.
Lovely, thank you so much. So first of all, my name's Rose Lynch. I'm the Senior Commissioner Manager for Primary Care Dental in the East Midlands. I am in attendance of my colleague Cara Pitcher, who is currently on annual leave today. She is the integrated care system lead for Lincolnshire, but I am attending in her absence. Firstly, I would like to thank the Lincolnshire HOS Committee for inviting NHS England Improvement back to the meeting to provide an update on the NHS dental services within Lincolnshire. The paper has been developed by the NHS England Commissioning Team Senior Managers and also our consultant in dental public health and our public health colleagues in Lincolnshire County Council, who, as you've just said, have joined us today on this call. We've also got in attendance, as you've mentioned, the Chief Regional Dentist and our local dental network chair for Lincolnshire, and also representation for the Lincolnshire ICS, who are soon to be known as the ICBs from the 1st of July. The purpose of input and attendance from relevant colleagues is in line with the direction of travel of collaboration, which is in line with the ICS integration agenda, hence obviously why we've got quite a few of us on this call. I'll take the paper as read. It's quite a lengthy paper compared to the previous, but we wanted to provide you with a summary overview of the pertinent points, which has been taken from the submitted paper to the committee. So it's important to know for the committee that the challenges we see today in NHS dentistry existed prior to the pandemic. And this wasn't any different for Lincolnshire or any other area. We had issues such as access and also the growing discontent in the profession around the dental contract. However, each area has its own challenges, and Lincolnshire's challenges are listed in this slide, as you can see. The challenges are further increased by the geography of the county, which we recognise, and it is the second largest in England. The travelling times as well around the county can also be considerable, and these are areas of rurality and also the coastal areas, which are recognised by the government as more complicated areas, which does affect the service delivery within. It's also to note that with areas of deprivation and a change in demographic population, is that there are more older people, so therefore obviously it's an ageing population. This slide gives an overview of the location of NHS dental services, which is explained in more detail within the paper. You can see on the right-hand side on the picture there, were the red areas. It highlights the what is recognised as the area that contains 13.5% of the population of Lincolnshire that's associated with the 20% most deprived in the county. It is illustrated that the distribution of practice can also be seen to be of a high proportion in more of the urbanised areas as well. Taking the location of services and looking at this in slightly more detail, this slide shows you that all dental practice sites are accessible by car within 30 minutes during rush hour. So this is indicated by the green shaded areas. So I'm not sure you can see my mouse, but this key here is obviously by car, and it's obviously in the rush hour time. And then the shaded colours in green denotes obviously the time that's accessible to these practices. So these circles here say that there's 18 practices within this area, and then obviously 8 here. And then you can see the difference in the green shaded colours, and obviously the yellow denotes the 30 minutes. The next slide provides a view of public transport, and it's clear to show that there are difficulties in accessing dental practices through public transport. And again, the dots represent difficulties in reaching dental practices. So where I referenced the dots in the previous slide, here you'll see that you've got some lines. I'm not sure you can see my mouse moving. And then where you've got these dots around these lines, these are the roads. So you can see obviously how it disappears, and then it's obviously more 30 minutes, and it's quite difficult to actually access those dental practices in that area. I will now hand you over to our Regional Chief Dentist, Adam Morby. He will talk you through the next few slides from a clinical perspective.
Good afternoon, everybody. I'm Adam Morby, the Regional Chief Dentist, and alongside this role, I'd just like to point out that I am still a practicing dentist. With this first slide, what I'd like to just try and point out is some of the issues around decay that's experienced by some of the children in the area. As you can see from the graph, what this actually depicts is in the Boston area, if you lined up a couple of children, one of them would definitely, when they open their mouth, you'd be able to visibly see decay in their mouth. Compared to South Kesteven, you'd probably be able to line up 10 children where only one of them would have decay. And I think on the next slide, it quite nicely shows on the map why this situation comes about, because you can see the blue shaded area. There is fluoridation of the water supply in the west of the region, but nothing in the east, and that's why we have this disparity in a situation. So this would be my call to you, because obviously prevention is better than cure. Over 38,000 children in a year have to access hospital services for removal of decayed teeth, and this isn't something we'd like to see for the younger population within the Lincolnshire area. So 70% of population benefit from fluoridated water across the UK. So hopefully, if we can sort of push this through with the royal assent that's now been given to the Health and Social Care Bill of 2022, because if we could get water in the other areas of Lincolnshire, it will actually reduce by 25% the experience of dental decay of the children in those more deprived areas, which are associated with the East Coast area. So, and one other thing to actually just point out as well is in the next sort of year or so, Anglian Water actually removing all of the fluoridation from the water due to repair works and changing of the infrastructure of the water supply. So it's quite crucial that we do get this turned back on, and if possible, for the whole of the county. So what we do need to talk about is some of the solutions, really. And obviously we work very closely with all the people that you can see on the call today. So we work with the consultants of public health, we work with the local authority, local dental network, integrated care systems, and sort of other patient representatives such as Health Watch and people along those lines. And working with the County Council, we need to sort of come up with the Joint Strategic Needs Assessment refreshment, and then that will really sort of help integrated care systems, working with all the other colleagues down at that local level to be able to come up with some new and different novel ways, working with the communities in those areas and the practitioners to look at what will be a better way of trying to find solutions to some of those problems. We realise with the workforce issues, we do need to try and attract more people into the area. And this is where we've got the Golden Hello scheme, which has just had approval. And this is where we'll be able to incentivise sort of existing practices to attract people into the area with a Golden Hello, and hopefully this will be quite a game changer in attracting people into the area. We're working with the comms teams as well, so that we'll be able to get all these sort of key points of information out as services change to people on the, as has already been mentioned, on digital platforms. So that will be quite useful for people. And with the secondary care services, we're working with the Get It Right First Time team to actually look at ways of improving delivery of services across all the different providers that we have in terms of orthodontics and oral surgery. So this will hopefully benefit with people in time with gaining access to treatments and reducing some of the waiting lists that we have in the area. I think that really just concludes some of the things I just wanted to draw attention to at this point in time. So thank you.
Thank you very much for that. I've got a question, Councillor Arnold.
Thank you, Chairman. It's questions, statements, comments on the report. The report is very detailed, but when I read through it a couple of times, it seemed to show to me that dentistry, national health dentistry in Lincolnshire is in a significant problem. And indeed, it's not entirely clear, I think, from the experts in terms of how you actually address the issue. It does strike me that national health dentistry in Lincolnshire is rationed. It's rationed as a consequence of not an awful lot of dentists wanting to do it, and not an awful lot of dentists who do want to do it want to do very much of it. And it's rationed by the contracts that are operated or put in place within the National Health Dentists, and it's rationed to a great extent by the actual model of service that's been provided. 24-month checkups. It doesn't strike me as being something that is particularly good in terms of preventing dentistry type problems. I also looked at the way there was a worry statistic as well in there that effectively 1 year's worth of dentistry has been lost because of the pandemic, and I did then consequently look through the report to see what measures were being put in place, and some of them were just being referred to in terms of, right first time and all these sort of things that we hear time and time again as going to be the marvellous solutions to all the problems that we've got. But there was very little then to actually deal with the issues associated with 1 year's worth of dentistry being lost. And the actual additional costs that were being put into the system to actually address it seem to be absolutely minuscule from my point of view. The graphs showed that there is an awful lot of our population that is not getting any form of dentistry at all. And it strikes me that because of the fact that a lot of people who can afford it have gone private because that is the only way you can actually get proper dentistry, that the people that are not in the dentistry system are the perhaps more vulnerable ones that can't afford it and can't gain access to it. And that is very worrying because they will be the old, the less wealthy, and perhaps children as well, particularly, which was just being referred to. And we can fluoridize as much as we want, but there's still going to be a need for dentistry, and if it's not there, it's not going to happen. So I was very disappointed. Well, I wasn't disappointed to a certain extent. It follows on from the report that we had previously about 6 months ago, but it's good to see that there's a good amount of information. And going back to the east side of Lincolnshire, you can say that it's not being fluoridized, the water, but there's no dentist there anyway, so it doesn't really make any difference whether it's fluoridized or not. There's still going to be a need for seeing dentists that don't exist. So it does strike me that dentistry is likely to be going the same way as eyesight tests and glasses and all these sort of things, hearing, and it is part of the way there already in terms of you have to pay a cost associated with, a part cost associated with any treatment you do manage to get. And we're going to end up with, as we have in those other forms of healthcare, a two-tier system where the people that can afford it can get it, and the people that can't afford it can't get it. And as far as dentistry is concerned, maybe that's exactly what is intended, unfortunately, because people don't die of, not rarely die of poor teeth. So it's really not got the incentive, perhaps, within the NHS system as a whole to actually be addressed and dealt with properly. And there doesn't seem to be anything here that suggests that that's going to happen in Lincolnshire either.
Thank you. I don't know if our NHS colleagues would like to say anything on that.
Yes, I can come back on some of the clinical points there and some of the other issues that were mentioned. It's widely recognised that the contract has been an issue and there are negotiations currently ongoing, so I can't actually say too much about that at the moment, but government does recognise and the Minister does recognise that there are issues with the contract, and those will hopefully be addressed in the very near future. They are sort of working on some details that will hopefully be released soon, so I can't really say any more than that. In terms of NHS and private sort of distribution, the big problem is that the practices we're contracting with are independent services. They're not like GP practices. As independent providers, they're working in the economy that we're all having to struggle through ourselves at the moment with increasing costs. And this is where practices then decide to, for the economic and reasons to make their practices survive in this economy, they decide the split between NHS activity and private that they're able to offer. And this is where some of the issues have arisen that you may have had in your mailbag, issues where patients are saying they can't get in NHS, but they can be seen privately. And this all depends on the amount of activity that a practice is able to offer on the NHS compared to their private ability. But it's a very difficult, challenging situation to actually recruit and attract new people into the area. This is why we tried to bring in the Golden Hello system, and we're working with Health Education England currently to try and look at ways of sort of introducing new sort of people and workforce into the area, and there has been some investment that's going to be spread over the next 3 years to help drive this. And we're looking at this with Health Education England, who have analysed the movement of dentists over the years, which has been to more of an urbanised area, and we're looking at ways to try and reverse this trend and try and incentivise people that have moved more to the private, or practitioners that have moved more to the private side, to reinvigorate them to come back to the NHS. So those hopefully will be solutions that we'll be able to bring about in the very near future.
Can I comment in terms of the vulnerable patients that Councillor Allen referenced? So we have had approval to progress with a pilot for urgent care vulnerable groups, including the homeless and refugees. It will be across East Midlands. Work is currently progressing with the team, and that's for access for areas of high deprivation through an outreach service. So that's currently in progress. So hopefully we can have something out soon within the East Midlands to obviously iron those particular patients.
Thank you. We've got Councillor Smith next, please.
Thank you, Chairman. And I hope this isn't construed as a party political point. It certainly isn't meant to be. It's good that the presenters have been honest and say that the problem actually stemmed from the 2005 contract change. Because basically, the government of the day and future governments since have not wanted to pay dentists for the work they've done, because pre-2005 it was per unit. So if you did 2 fillings, you were paid for doing 2 fillings rather than per activity, which is what the situation is now. That's what's caused a mass exodus of NHS dentists, because I can remember it very clearly being able to go to my dentist when I was in Salisbury at the time, when I was a young boy, one day, and then the contract changed and I couldn't. And I, obviously being that age, you didn't understand why. But the government, I'm glad to hear that the government are starting to now finally pay attention, but it's to be blunt, it's too little too late. You know, Lincolnshire has had a problem with dentistry particularly. I mean, I know it's national issue, but Lincolnshire has suffered particularly badly since I've been in Lincolnshire, and I've been in Lincolnshire nearly 20 years. You know, this is not a new problem, and the government has reacted far too slowly. In terms of the pilot, that is good news to hear, but what that doesn't solve is somebody like my mother, who is on the minimum wage and working, who isn't entitled to benefits because she's working, and it costs about a band 2 treatment, which is to see a hygienist, is about £60, Chair. So you imagine the minimum wage, imagine it's £100 to fill your car up, it's an hour to get a prescription if you're not medically exempt. So there's 2 hours that you've worked straight away and you haven't actually taken anything home. That's before the taxman takes what the taxman wants. You're going to have a massive problem, and you're going to get people like my mother who simply won't see a dentist because they can't afford to. And then you are going to have a systemic problem. Even if you are on a dental plan, and I've taken the decision to do that for various reasons, that isn't cheap. That's £30 a month. I do get the right to see my dentist 4 times a year for that, but you add that up, that's a lot of money. You know, that's a heck of a lot of money. As Councillor Ann said, we are already halfway there. We're very much like opticians, where it's basically, for none intents and purposes, it's really a private practice, essentially. You pay a proportion of your treatment costs, but actually, it is a private practice where you don't get as much say in what treatment you can have because the NHS pays part of the bill. And then there needs to be a serious conversation around, are we going to rectify that, or is it going to stay the same, or is this where it stops, or is it going to move further, very much like opticians? And if it is going to move further, what I would consider the wrong way, as in a more private system, then there needs to be I think we as a committee need to have a serious conversation with government and say, actually, what are our residents paying national insurance for when dentistry is okay? You're not going to die from it, very rarely, but you need to live. You need to have a good, fulfilling life, and being able to have proper care and treatment for your eyes, for your teeth. That's part of that process. And as Councillor Ann said, around the years lost worth of appointments, there doesn't seem to be. While I appreciate things are trying to be done in that paper, there doesn't seem to be much to say by X time frame this will be rectified. So you will constantly have this huge backlog that's never going to go away. And that's going to cause massive problems, especially for those who aren't able to be on a dental plan, because you have your appointment, you then have to put a deposit down for your next appointment. So you're waiting about another 3, however long somebody feels they need to wait financially, to then put a deposit down. So actually you're probably seeing a dentist, if you're lucky, once every year and a half, maybe every 2, because it's not. That's on experience on how much people are waiting from one appointment to another due to having to put deposits down. And if you're doing that, as Councillor Ann said, 24 months. That's far too long to see a dentist. It needs, the advice I was always given is it's a minimum of once a year from many dentists I saw over the years. And if you don't do that, that's when you start getting problems, especially in areas of deprivation, because you're already on an uphill fight as it is, Chairman. Thank you.
Would you like to respond to that, please?
So just trying to come off mute there. Sorry, yes, no, I totally agree with the councillor, and the points he's made. I actually can't see him on screen at the moment, but totally agree with some of the points you've raised. The National Institute of Clinical Excellence does recommend a varied number of recall intervals for patients, from sort of anything from 0 up to 24 months. I totally agree with the point that some, majority of patients may be best being seen within a 12-month period. But dentists are struggling to get patients back in because of the circumstances they're in at the moment. And whilst we are trying to increase activity with practices, it has improved because of the changes in the standard operating procedures. So at the moment, as it currently stands, practices are able to practice a little bit more like what they did before the pandemic. So hopefully the numbers of patients that are being seen will be increasing in the near future back to those levels that were before the pandemic. I think my colleague Kenny would like to probably come in there as well. Thank you.
Thank you, Adam. Just to say, as well as being chair of the local dental network, I am a practicing dentist as well. I've been in Lincoln over 40 years now in one practice. So I've seen things, over a long period of time. The the point about fluoride, many years ago, they took fluoride out the water supply in Lincoln for a very short time. But at ground level, we could see the difference that made. It was significant. So I would urge everyone to support the fluoridation for the whole of Lincolnshire, please. Also, it was mentioned that you don't die from toothache, and that was mentioned by 2 councillors. Poor oral health has a huge effect on an individual's well-being. Bacteria in the mouth can cause can be attributed to heart disease. It can make diabetes worse. You know, bacteria in the mouth in an elderly person, you get potential aspirational pneumonia. Dentists also just don't look at teeth. You know, regular checkups, we can pick up cancers and things. So, you know, we have to appreciate the importance of good oral health. Another point I just wanted to make was from minute one, the NHS contract was only commissioned for 50% of the population. It's not a full 100% population. So from the outset, we were never going to see all the patients on an NHS contract. Thank you.
Thank you. I've got Councillor White next.
Yes, I'd like to ask, are children totally dependent on their parents taking them to the dentist? And also, how are you carrying out this oral health needs assessment in Boston, please?
Do you like me to come in there? I don't know. So yes, so children would be dependent on their parents or carers to take them to the dentist, because obviously they are children still. So it is important to keep a record of children who was not brought, because obviously it's out of their own control. With regards to, sorry, what was the second question again? The
Public Health, it says on 13.7, are carrying out a rapid oral health needs assessment. My point is that if your children are dependent on their parents, which they didn't used to be, they used to be the school dental service, then it seems to me that it's obvious that the most deprived members of the population are not going to get dental care.
Lucy, you'd like to come in?
I can come back in on that second point around the needs assessment. Yes, so we're collating information from lots of different sources. So some of it is, for example, dental access rates, but we have also what's called the Dental Epidemiology Survey, which is run every few years, and that goes into schools directly. So an organisation called the Community Dental Service, who work across Lincolnshire, they go into schools and they do assessments of the children in school. So it's captured that information from a range of different places, not just reliant upon kind of children who are going into dentists.
Thank you.
Okay, thank you. I've got Councillor Linda Wotton.
Thank you, Chairman. Basically, Councillor White asked my question, but I was horrified to read in the national press that thousands of children up until the age of 19 had to go into hospital to have extractions because of rotten teeth. And I was going to go on and say, do we still go into schools and see children and educate them? Because sometimes the children can educate their parents. And also, as you've just established, Councillor White, are the children subject to their parents being signed up to a dentist? I mean, I'm really fortunate in Grantham that I still have an NHS dentist who's amazing, my Dr. Daniel. He's Polish, and I really appreciate him. Thank you.
Yeah, if I could just come back in on the point around support for kind of children kind of in teeth brushing. We have a number of different programs that run across Lincolnshire. So we have something called the Lincolnshire Smiles program, which again is run by that community dental service. They go into particularly early year settings and they do supervised toothbrushing programs and support in those settings with the caregivers understanding how to look after children's teeth when they're in their care. I appreciate that's only part of their day or part of their week, but it's trying to build up those good habits for life in children and young people from a really young age. We're also just starting from this summer to work with the Holiday Activity and Food programme. So we'll be distributing toothbrushing packs and supporting again with helping children to understand how to brush their teeth and kind of how to look after their teeth, things around drinking water, for example, rather than kind of sugar-sweetened beverages. So we do have a number of different activities that we target to working directly with children in settings that perhaps don't necessarily involve their parents, but also it's really important that we have those conversations with parents as well. So in Boston, for example, we provide oral health advice as part of the health visiting program, but in Boston we've enhanced that. So at the 6 to 8 week visit, so when babies are really quite young still, again we have a more of a focused conversation around oral health, provide toothbrushing packs that are appropriate for that age, so that kind of very young children and parents get used to looking after teeth and gum health and things from that early age. So there are lots of things that we can do to build prevention across the county. Yeah, absolutely. It's important as well, though, that those children can get into a dentist. Thanks.
Thank you. I've got Councillor Cleaver next.
Thank you, Mr. Chairman. My major concern is the availability of NHS dental services, simply because it's the one thing I keep hearing about, and I know it's anecdotal, but I've heard more about it now we're coming out of the restrictions that were placed during the pandemic. We're now supposed to be at 90% capacity, and yet the number of complaints I'm receiving has actually gone up exponentially. And if you look at the patient pathway, go onto the NHS website. It says, and I'm quoting directly from it now, the NHS will provide any clinically necessary treatment needed to keep your mouth, teeth and gums healthy and free of pain. Now, that is a policy commitment. That's on the national government website. And yet we still find, because this came up the last time this was discussed by this committee, we still don't know how many people are not getting that treatment and how many people are not getting that care. So it begs the question as to how this is being rationed and what steps are going to be taken to actually measure how far short we are of supply and what's going to be done about it. As simple as that.
Prior to the pandemic, excuse me, I think it was just it was less than 35% of the local population actually accessed NHS services within Lincolnshire. Obviously, and this draws back to what Kenny said, there's always been funding there for people to access dentistry, but it's never been for 100% of the population. And actually trying to 100% understand the numbers that are trying to gain access is an extremely difficult thing to try and do. All we can actually do is compare population statistics compared to those numbers that are actually attending, and that will tell us roughly a number that aren't, but we don't know of all those that aren't how many do actually want access, because at any one point in time there was always less than 50% of the population that did want access. And through the pandemic we did manage to, even though the threshold at the moment for practices is 95% activity, we did manage to keep activity levels to about 72-73% of those patients that were attending prior did manage to still gain access through the pandemic. So yeah, that's just a little bit to help with an appreciation of the statistics.
Thank you for that. I'm still anxious that we need to take account of the number of people who are attempting to obtain NHS care and are not able to access it. Thank you.
Got Councillor Rice-Oxley next, please.
Thank you, Chairman. Yeah, first and foremost, I wholeheartedly support the fluoridisation of water across Lincolnshire. So we've heard about some of the very serious implications of poor dental health. My question is actually about dentistry for pregnant women. Very helpfully, brilliantly, if you are pregnant or for 12 months after you've had a baby, you're entitled to free NHS dentistry. And again, because of the health implications, and I know they drilled it into me when I was going to different classes and stuff, you know, how important it was that you kept seeing your dentist. They do make that point, because I think pregnant women are particularly prone to tooth decay or something's going on, which is why you're entitled to it. But given the difficulty of accessing NHS dentistry in Lincolnshire, I note Councillor Cleaver's comments. Given the overall difficulty, you know, I had an NHS dentist my whole life until I moved to Lincolnshire, and now I have a private dentist. My children obviously are still NHS, which is excellent, because our private dentists do obviously give NHS care to our children. So my question is, are women who are entitled to free NHS dental treatment because they are pregnant or because they are within 12 months of having a baby, are they supported, are they given the information and the access that they need to access that NHS dental care? Thank you.
Obviously, through the pandemic, there was quite an issue of people accessing, and there still is the issue of accessing NHS dentistry. But it was a matter of sort of the funding arrangements for dentistry through the pandemic, that it was highlighted that any patient with clinical or urgent need was prioritised over another. So obviously, females that are pregnant would fall into that category, and if they had issues, they should have been able to access services. And likewise, children, it was also recognised that the numbers of children being seen was reduced, and the Chief Dental Officer actually put in place a toolkit to help practices guide to help see more children as well. So certainly those would have been prioritised through the pandemic, and should still be, anybody still with the clinical urgency or treatment needs should be prioritised.
Thank you. I've got Councillor Chalmers next, please.
My question very much relates to the last, so that works out really nicely. I've got a 2-year-old, and during the pandemic, I should have been entitled to free dentistry. I wasn't. There's no catch-up, apparently. I've just at risk for losing teeth because I've given my calcium to my babies, which brings me on nicely to what Lucy said about getting, again, I live in Boston, babies and children, toothbrushing, encouraging parents. I've not seen any of that. I'm also more than happy to pay privately, but I've just failed to get an appointment, full stop. And again, on the fluoride, 1000%. And it is something that we've brought up with Anglian Water at Boston in local council meetings, that we do want that as an area to help prevent tooth decay. So why is there no catch-up for pregnant women or women that were entitled during that period? And where are you getting your statistics from, Lucy? Because I've not seen any of what you've said to be true to relate to my own age-specific situation.
Yeah, Lucy.
Yeah, I can come back in first. So the this Boston specific program should be rolled out as part of the Health Visitor program. So when you had a 6 to 8 week visit, which I appreciate will feel like a really long time ago, but that's where the initial conversation starts in terms of providing that kind of learning around looking after babies' gums and teeth as they develop, and toothbrushing packs come out. The did you want to come back? Sorry.
Yes, that would be where the system fell down, because during the pandemic we didn't see that particular area of care.
Thanks, that's a really good point. Something I can pick up. I'll pick that up with the Health Visiting Service and just make sure that we can make sure that those packs are getting out to people that missed them, because that, as you say, that's a big gap that we need to pick up.
Thank you.
I was going to say clinically in practice as well. Obviously, this is a starting well sort of program, so practitioners always make get across all the oral health messages to children or the parents at that sort of early age for their young and developing children as well. So it is accounted for quite a bit.
Thank you, Chairman. I just wanted to, shall I say, reassure the presenters that whilst I wasn't aware quite of the severity of the conditions that you could be caused through poor oral health, I am acutely aware of the pain that can be caused by poor oral health and its importance, which is why I foot the bill for what I wish to do in my own personal circumstance. Coming back to Councillor Cleaver's point now, and this is very important, that the section you quoted, I can tell you categorically that doesn't happen, because even if you are an NHS patient, a band 3 treatment is about £250, and people simply do not have the money spare to do it. So there will be people, and my mother is one probably, and I'm sure there are many thousands of others who simply do not have a spare £250 to put into getting this sorted, and who won't be entitled to it because they're not on benefits, they're not claiming the right benefits. So they are a forgotten class of people, if you like, that we, as an authority, we need to lobby our own, and as a committee, we need to work with our MPs to lobby the minister, because I appreciate that's not the fault of our presenters by any stretch. And in terms of being able to be seen during the pandemic, I must have been very lucky then, because sorry, Sam, did you want to? Oh, sorry. During the pandemic, I must have been very fortunate then, because I was able to be seen from the second lockdown. I was actually able to be seen at least twice, possibly 3 times. So I must have been quite fortunate but I did travel quite a distance to Lincoln, because that's where my dentist is. But I'm very, very, very thankful for my dentist and the service they provided me during the pandemic, because I would be I'd have my own major issues, I think, if I hadn't been seen for that length of time. I appreciate the job that dentists are doing, or are doing is difficult anyway, and were doing during the pandemic was exceedingly difficult. And I don't want the presenters to think that we're not sympathetic to that, because we are. But as the paper says, these problems have been systemic before the pandemic, and we as a committee or as individual councillors need to try and do as much support around the fluoridation and the contract as we can within our limited power on this, because it's been going on too long, and our residents, to be honest, and as taxpayers and ratepayers, deserve better than what they've had. Thank you, Chairman.
Thank you. I've got Jasmine that wants to come in.
Thank you very much for that. Yes, absolutely agree with you. When we look at access to services, it's not just about availability. It is about, yes, accessibility, availability, the accommodation, the acceptability of the services to patients and public, and also affordability. And affordability has been mentioned twice now. Yes, those on certain benefits will be exempted from paying NHS dental charges. But if patients are really struggling, as you say, they're not claiming, they're on a low income and they can't afford NHS dental charges, there is the NHS low income scheme that patients can apply for, which could help them with regards to payments for NHS dental charges. And that I think we need to increase awareness of for patients and the public, so that they are more aware of it and can apply for the benefits. With regards to pregnancy, there is no loss of calcium from the mother's system during pregnancy to make baby's bones or baby's teeth. The issue about pregnancy is about the hormones that can cause more gum bleeding, morning sickness, which can affect what we call erosion of the teeth. And also in pregnancy, dietary habits change because women are snacking and eating more, and therefore they will be more at risk about changes in oral health. And that's why we absolutely support dental checkups in pregnancy. With regards to the reference to NICE guidance on 24 months dental checkup, I think Adam covered this earlier, but then I had some internet connectivity issues. It is the longest gap. 24 months is the longest gap. Not universally that NICE is recommending that we have we leave 24 months, 2 years for every patient. What NICE does recommend is that a dentist assesses this on risk of each individual patient. So patients may need to attend every 3 months, or every 6 months, or every 9 months, or every 12 months, or for some, like myself, every 24 months. So that is dependent on the patient's oral health status. And then the last point, going back to one of the councillors earlier, if patients need to see a hygienist, and that's only for a clean and a clean of the teeth and gums, that doesn't really go into band 2. That will still be in band 1. They should be paying band 1 NHS charges for a scale and polish. Thank you.
Thank you. Kenny, you want to come in as well?
Yeah, thank you very much. Thank you, Councillor Chambers, for your comments. That's appreciated. Thank you. Just like to point out that dental practices were closed for a very short time, something like 6-7 weeks. And then, since June 2020, we did go back face to face. So from the outset, we were treating patients. We do feel for the patients who are unable to access treatment. No one's happy about that. But also we have a collective responsibility for ourselves. Dental decay, as was pointed out earlier, is the biggest reason for admission to hospital for general anaesthetics for children. And whilst fluoride has a huge benefit, it's not a magic bullet. Fluoride can only do so much, but if an individual is drinking a 2-litre bottle of Coke every day, or their diet isn't the way it should be, they're going to get tooth decay. And I think, that's something we have to realise as well, that we all have I
think he's frozen up. Okay, we'll move on for now, I think. So I've got Councillor Chalmers who wants to come in again.
Yeah.
We'll have a...
Oh, is he back?
Are you back now, Kelly?
Yes, sorry. At what point did I leave?
You said that patients all have I think you froze.
A collective, we all have a collective responsibility to look after our own teeth, really. And the bit about fluoride is it's not a magic bullet. If someone is drinking, a 2-litre bottle of Coke every day, they're going to get dental decay. Dental decay is the most common admission for general anaesthetics in children for general anaesthetic extractions.
Okay, thank you. We'll go back to Councillor Chalmers now.
Thank you. When I was a young girl, I used to go straight from Boston High School, skip down the road and go in for a dental checkup. I would have been probably about 14 plus. I tried to book this same checkup situation with our local dentist, which is an NHS dentist, and they said, no, absolutely not. We won't let you send your child without you being here. Now, I've got my own business and it's quite easy for me to schedule time off. That's not a problem. But if I was working in a factory, had 3 children, or was on minimum wage, and then that extra time away from work all of a sudden becomes a big problem in accessibility for parents sending their children for just a checkup or a filling or anything. When did this change, and can it change back, please?
This relates basically to a consensual issue. So basically under 16s really do need sort of consent to come from a parent or a guardian of one description or another. So that's more of a legal government driven requirement, I'm afraid.
But if I've booked the appointment, then the consent's there, and then it's just a phone call if there's work to be booked in, because I don't think I've seen a dentist in the last 10 years that's done a job there and then. It's always you'll need a secondary appointment.
Yes, point taken, but if it is a job that they can do there and then, obviously in the efficiencies of time that we have to extol in this current climate, we're trying to see patients on a minimum number of appointments to reduce obviously all the instances with contact with virus and potentials in that respect. So it's trying to be efficiency of a service, because if we end up having to get everybody back for another appointment, it just makes the waiting lists even longer, unfortunately, and reduces access.
Thank you. I've got one more question and then I'm going to close down the debate. So it's Councillor Harrison.
Thank you, Chairman. I don't know whether colleagues are aware or whether the speakers are aware, but the DWP is about to run a very, very high-profile campaign to get more people who are actually qualified for benefits but aren't clearing. But that actually opens the door for quite a lot of other benefits, which include dental services, and there will be parents with young children come into that bracket as well as older people. So I'm wondering how on earth, or is any preparation being done for this huge increase of patients? Thanks.
sorry, I can't really answer that question. I'm not really too aware of that situation myself because that hasn't been brought to my attention. So I don't know if one of my colleagues can answer that at all.
Neither am I, Adam. I mean, for commissioners, we commission new services based on oral health needs assessment, which is why we work collaboratively with our local authority colleagues, based on obviously areas of need and demographics. But in terms of DWP and their campaign, I'm afraid we're not aware of that. But I should just give some insights to how we commission services, patients in the NHS.
Thank you to the councillor for drawing it to my attention as well, because I'll certainly go back to the national team to actually see why what's happening in that respect and what plans are being sort of built into future negotiations on that. Thank you.
Thank you.
Okay, thank you. I've just got two questions, if I may, and that is, what has been the main reason for a lack of interest in securing a new provider for dental services in Mablethorpe, and what can or has been done to make this more attractive?
I'll come in that on commission perspective. So as Adam and Kenny have mentioned, in the obviously had pandemic, dental services were closed and the priority wasn't urgent. So we did commission an urgent dental service in Mablethorpe to ensure obviously patients have access, but we understand that that position has now changed, and quite rightly so. Patients obviously want a more routine. So there is the procurement is progressing. We're hoping for the service to be in place for year 22, 23. So that's not the financial year, but obviously the annual year, because obviously we are seeing quite a lot of access needs in those areas. So we are prioritising Mablethorpe at the present moment to obviously have a service in there for patients.
Okay, thank you. And then can you expand on what areas have seen NHS contracts handed back and what impact this has or will have on those patients?
Yes, so in the paper, it tells you that we've had handbacks of contracts, and what we do as commissioners, first and foremost, is the patient letter. We need to ensure that messaging to the patients is accurate and it's not signposting to private element. That's really important to us. That letter is agreed with ourselves before it is shared with the patients of that practice, and obviously appropriate signposting. And what we do, and if any practice do terminate their contract and relinquish, is we look at the area of need and we disperse the activity within that area. We don't like to lose that activity. If there are no expression of interest within a particular area, then we do go wider in terms of geography, but it does stay within Lincolnshire, and we do link in with our public health colleagues as well in terms of area of need as to where obviously we commission that. But what is for assurance, if there are any terminated contracts, we do keep it back in the system. It's maintaining that access. And then building on what I mentioned before regarding working with public health for the oral health needs assessments, that's how new services are commissioned when there's an identified gap.
Okay, thank you. Councillor Matthews, you've indicated you want to speak, and as you haven't spoken so far, I will allow you to.
That's very kind of you, Carl. Thank you very much. And it was really just to go back to Rosemary and ask her if she wouldn't mind answering your question about services in Mablethorpe, because although she said she's prioritising it for a 23-24 service, we haven't got a dentist now. We haven't had a dentist for a year. We won't have a dentist next year, it seems. I would really like to know when there will be a dental service available to the people in Mablethorpe, please. And that's not, I'd like a date or a time or a number or an amount. I don't want a prioritising or we're working on it, please. Thank you.
It's in the year 22-23. So originally it was supposed to be in place by 1st of April 22. 1st of April 23, but due to the impact of the pandemic, that has been slightly delayed. But as mentioned, that is priority. So we're looking probably April, July time, hopefully, if things obviously go to plan as part of the procurement timeline. We're hoping for services to be in as soon as possible.
So in essence, another year now?
Yes, to being honest, yes.
But you'll guarantee that service is available in a year?
That's the timeline we're working to.
Only that we've heard this story before. and
Yes.
we'll be watching carefully. Thank
It
you, Carl,
is
for that.
priority on my agenda, Councillor Matthews.
Thank you very much.
Thank you.
Okay, thank you. I'm going to bring this to an end now. So I'm going to propose that we note the information presented by NHS England and NHS Improvement Midlands on NHS dental services in Lincolnshire, and to request a further update in 6 months' time. Do I have a seconder for that proposal? Thank you, Councillor Linda Wootton. All those in favour, please show. Thank you, that's supported, and thank you to all our presenters today, it's much appreciated. We'll now move on to agenda item 10, which is the Lincolnshire Pharmaceutical Needs Assessment. Over to you, Simon.
Thank you, Chairman. The committee's working group met last month and worked through the 63-page document, which is the draft, the consultation draft of the Pharmaceutical Needs Assessment, and the working group's response to that is set out on pages 397 and 398. Essentially, the working group supports the conclusion which is set out in the draft document that the current provision of pharmaceutical services in Lincolnshire is adequate and is satisfactory. So that is really for the committee's consideration. Thank you, Chairman.
Thank you, Simon. Have we got any questions? No, in which case I'd like to propose that the committee's response to the consultation draft of the Lincolnshire Pharmaceutical Needs Assessment, as set out in Appendix A to the report, be approved. Do I have a seconder? Thank you, Councillor Allen. All those in favour, please show. Thank you, that's supported. In which case we'll move on to agenda item 11, the work programme. Simon, over to you again.
Thank you, Chairman. Just if I could ask members briefly to look at page 401. We've got the cancer care update listed for next time on the 13th of July, and then the item which is currently titled Staffing Challenges, but it's an overview of the recruitment and retention issues, if you like, what the NHS is calling their people plan for Lincolnshire. So that is the second item, and an update on what is going on north of the border. Sorry, the Humber Acute Programme, which is north of the Lincolnshire border. Sorry, that. And then we've got 3 items listed for September at the moment. Thank you, Chairman. I think obviously we've got to pick up the updates. There was no timescale for any updates in the first item, but that may be a matter for me to inquire with the CCG or the ICB from next month in terms of what their implementation timetable is. I'll leave it there, Chairman. Thank you.
Thank you, Simon. Do we have any other comments on the work programme? No, so we're happy to. Councillor Cleaver.
Yes, it was in the Chairman's announcement supplement about the CQC report on Lakeside Healthcare Stamford coming out. So can we, obviously I should prefer that to be in the July if we can. I see there's only 3 items on the agenda at the moment, but if not, if that's not considered appropriate, to do that in September. I also note that Lakeside Healthcare did appear, and I don't know at whose invitation, before the Rutland Health Scrutiny Committee, even though they don't have a practice in Rutland. And I wonder whether we should be inviting them to come before us or the CCG.
Sorry, the Lakeside Healthcare, why they, well, I suppose in the case of Rutland, the Rutland Committee issued an invitation to them and they accepted that invite. This committee has worked on the basis of asking the CCG as the commissioner or the contract manager of the service to present on Lakeside. But I don't know if that answers your question.
I'm open-minded about it. I just thought I'd point this out
to
the committee for consideration.
Yeah.
I say, given that they have appeared before Rutland, sorry, Leicestershire, LLR, Rutland County Council. Rutland County Council.
Rutland.
Yeah. Which I was surprised at when I found out about it, to be honest.
Right.
Yeah, and then I've got another one to come up with that.
Yeah, well, we can have a look at adding it to the work programme. We'll put that down. And you've got another one. Yep.
Yeah, sorry. Beg your pardon, I spoke to you about this, Chairman, earlier. and it's in relation to the presentation that we're going to have from CCG about GP services in October. And I have to say, I was quite surprised yesterday to see a tweet from the CCG, from our Lincolnshire CCG, which says patients across Lincolnshire can access appointments with a GP, nurse or other healthcare professional in the evenings and weekends, either through a local GP access hub, their own practice or a practice nearby. To find out more, please contact a member of your GP practice team. Now, that took me completely by surprise, and I'd be interested to have some comment about how accessible that is proving when our colleagues from the CCG come to talk about GP services in October, please. I can forward you the tweet, if I can copy of it if you want. Right, thank you. All right.
Okay, thank you. We've got that listed. Councillor Chalmers.
Thank you. Just in relation to the dental plan that we've just seen, they heavily spoke about fluoride in the water. Is there anything that we can put in the works programme to get that going, put it to another room full of councillors? What's the next step with that?
Yeah, I think we've spoken about this before, Simon. And is it the Children's Committee are dealing with the fluoridation side of things? It does get sometimes a bit sort of confused between all the committees we've got. And so I think that they're doing an active part, but nevertheless, I think I'd still like to see something come back anyway in regards to fluoridation.
Yes, can we put it back on the agenda as a let's find out what's going on? Thank you.
Yeah, Colin, you want to come in? Okay, Councillor Smith, in which case?
Thank you, Chairman. Simon, do we have a fixed date for the working group on suicide?
I am looking at I think it's the 27th, and I think I probably need to finalise that. I have been focusing on this meeting, but I need to finalise that probably tomorrow. Yeah.
Yeah, I think that was the earliest that we could sort of pull it all together realistically. Yeah. So, yeah. Okay. Any other comments on the work programme?
Yes.
Councillor White.
I presume we're going to see somebody from public health sometime, are we? In the, before the end of, in the civic year, are we? It's just some of the comments that Councillor Parkin made. I just wondered, and then we've said that some of them are doing something with dental health with children. It'd be interesting to know what they're actually doing practically in the county as far as improving public health. I mean, I'd be interested, that's all.
Well, the focus of this, sorry to sound bureaucratic, the focus of this committee is NHS funded services, which is set out.
Okay.
So another of the county council's committees looks at the public health function.
Yes.
But we do pick up, so for example, there are obviously links with public health. So for example, the oral health needs assessment is being led by the council's public health team. But that obviously links in with the
because
NHS.
What this lady said about the healthcare visitors have not been going into homes. I know that as well. Because I've got a grandson who's nearly 2 years old, and his mother has not seen a healthcare visitor. So, if they're not, they won't be able to do that dental work. Sorry, that's by the way.
Yeah, Simon, perhaps you could pick that up with Hugo, because it's obviously adults committee.
That is my experience. Having a baby over the pandemic is absolutely no support.
No, we'll pick that up with the other committee. Councillor Cleaver.
Two things there. I did raise with Heather about the question of health visitors, because it was omitted from a report that came to Children and Young People's, which I actually sit on. And she wrote me a long email explaining what was happening during the pandemic about the health visitor service. So it is quite timely to ask, I suppose, how much that has recovered since the end of the pandemic. And I'm quite happy to take that on board as a member of that committee. The other thing is, and I'm sorry to be so repetitive, I really don't want to let go of this issue of us not knowing how much unmet demand there is for NHS dental services in the county. I really don't want to let that go.
Okay, we'll try and pick it back up with them and see if we can get something that's sent out to the committee members. Anything further? No? In which case, I bring the meeting to a close. Thank you all very much for your attendance. Have a safe journey home. Thank you.
Thank you.
Thank you, Chair. Very well done. Bye.
Thank you, Colin. Bye.